Okay. It looks like we are live. Okay. Give me a second. Hello, it's Dmitriy again, and I want to do a chapter today from the Step 1 textbook. Again, this will be for, in this case, respiratory, but we'll be covering just that one section. This is not covering the cardiovascular overlap or anything like that, just the respiratory section itself. This is a sort of a moderate size in terms of chapters. It's not too big, it's not particularly small either per se, but then again, none of the chapters in this thing are particularly small. So I want to just set this up here. Here we go. That should be fine. Okay. And so again, I'm reading from the 2025 edition of the First Aid for the USMLE Step 1 textbook, a student-to-student guide. And the book that I have here on the PDF, I think, is a 2017 edition, if I'm not mistaken. Yeah, 2017 edition. So I will have the 2017 edition on screen, but I'll be reading from the respiratory textbook that I have in front of me from 2025. There are going to be some differences, but there's going to be a lot of overlap, so it's not that big of a deal. So, let's begin. Whenever I feel blue, I start breathing again, by Frank Baum. Okay, sure. Until I feared I would lose it, I never loved to read. One does not love breathing. That's the Scout from To Kill a Mockingbird. Okay. These quotes are just kind of goofy, but they put it in the front, so I might as well read it. Love is the interior to life, posterior to death, initial of creation, and the exponent of breath. Emily Dickinson. Okay. Love and a cough cannot be concealed. Okay. And here's the important part that's actually not in this textbook here, but it nevertheless is present. Key or group key respiratory, cardiovascular, and renal concepts together for study whenever possible. Respiratory physiology is challenging, but high yield, especially as it relates to the pathophysiology of respiratory diseases. Develop a thorough understanding of normal respiratory function. Get familiar with obstructive versus restrictive lung disorders, ventilation/perfusion mismatch, lung volumes, mechanics of respiration, and hemoglobin physiology. Lung cancers and other causes of lung masses are also high yield. Be comfortable reading basic chest x-rays, CT scans, and PFTs. Yeah, so here's the thing with the respiratory section, and it's true for some other sections as well. A lot of people like to emphasize for the Step 1 exam and for the COMLEX exam, they talk about, bugs and drugs. There's a lot of pharmaceutical questions, a lot of this drug does this drug does that, what are the side effects, what is it used for, when is it was it contraindicated, that kind of thing. And the same thing is talking about like bacteria, fungi, etc., viruses, what's the clinical presentation, that kind of thing. The problem is that all that's relevant, all that's necessary to do well on the exam, and there's a very expansive section in this textbook on microbiology, for example. But if you don't know the basics of how certain organ systems work, then you're kind of in a bad spot. So if you were only learning about respiratory, let's say, from your first year of medical school, and you haven't really talked about it or looked into it all that much since then, same thing is true for the cardiovascular system, etc., you're probably going to be in a bit of a deficit. So it was good to kind of recap on some of that stuff and look into the minutiae as well. So we'll get into that now. Respiratory section. Starting off with the embryology. So you can show the whole thing there. There we go. Respiratory embryology. Lung development. Occurs in 5 stages. Begins with the formation of the lung bud from the distal end of the respiratory diverticulum during the week 4 of the development. Every pulmonologist can see alveoli. That's a little mnemonic they only use EPCSA. Okay. So the first stage is embryonic. So because it says every pulmonologist can see alveoli. So we have embryonic, pseudoglandular, canalicular, saccular, and alveolar. So let's continue. Embryonic, weeks 4 through 7. Lung bud becomes trachea, becomes the bronchial buds, then the main stem bronchi, then the secondary lobar bronchi, then becoming the tertiary segmental bronchi. Some notes in here. It says here, errors at this stage can lead to tracheoesophageal fistula, tracheoatresia, stenosis, and pulmonary agenesis. Very true. Pseudoglandular, weeks 5 through 17. Endodermal tubules, becomes terminal bronchioles, surrounded by modest capillary network. It says notes here, respiration is impossible and incompatible with life. Well, yeah, obviously. Canalicular, weeks 16 through 25. Terminal bronchioles, becoming the respiratory bronchioles, then to the alveolar ducts, surrounding by a prominent capillary network. Notes here, it says airways increase in diameter, pneumocytes develop starting at week 20, surfactant synthesis, respiration capable at week 25. Finally, saccular stage, this is week 20, mine says week 24, they say week 26 in your PDF. I guess it doesn't really matter that much, but week 24 to birth. Alveolar ducts, terminal sacs separated by primary septae. And then alveolar, which is 36 weeks to 8 years. Terminal sacs to adult alveoli due to secondary septation. And there's more notes in your PDF as well about that. It says here in the PDF, in utero breathing occurs via aspiration, expulsion of amniotic fluid, leading to increased vascular resistance through the gestation. At birth, fluid gets replaced with air, leading to a decrease in pulmonary vascular resistance. Yes, and my book actually says in the notes, but at birth, 20 to 70 million alveoli. By 8 years, 300 to 400 million alveoli. So it's a pretty substantial increase, as you can see. Let me just check something to make sure I haven't made any redundancies on my part. Okay, fair enough. I don't believe so. Okay, good. The reason I say that is because I actually have read this section before. And wow. Okay, I did renal last time. Okay, I did renal before, I should say, because I remember reading another section besides the rapid review, of course, for the Step 1 textbook. But I wasn't quite sure if I also read this section before. I know I read it before, but independently. So I just wanted to make sure that I'm not beating a dead horse, if you will. And of course, I might have a different alternative studying method if I just have read this over and have a video, of course. I might just review it myself from the video. So this has a chart right here, as you can see. I have the same chart in my book here. It is an embryonic period, and then it transitions over into the pseudoglandular, and then the canalicular, the saccular. This is all in the fetal period now. Then you have the alveolar period and the postnatal period. And so the alveolar period really kind of begins in the late fetal period, but it doesn't really come to a completion until, 8 years, essentially. So again, it's 36 weeks to 8 years for that last alveolar period. Now let's continue. Choanal atresia. And again, I think your book is a little bit different in terms of how it's ordering some of this stuff. So, it just is what it is. Choanal atresia. Blockage of posterior nasal opening, often associated with bony abnormalities of the midface, most often unilateral. When bilateral, is an emergency and presents with upper airway obstruction, noisy breathing, and/or cyanosis that worsens during feeding and improves with crying. Diagnosed by failure to pass nasogastric tube beyond the pharynx and confirmed with CT scan. Often part of multiple malformation syndromes, such as CHARGE syndrome. CHARGE stands for coloboma of the eye, heart defects, atresia of choanae, restricted growth and development, genitourinary defects, and ear defects. So again, that CHARGE syndrome is related to choanal atresia. Okay, I'm just looking at your book now. Well, it's technically my PDF, but you get the idea. Okay, so my thing says lung malformations. They say congenital lung malformations, but whatever. Lung malformations, pulmonary hypoplasia, poorly developed bronchial tree with abnormal histology associated with congenital diaphragmatic hernia, usually left-sided, bilateral renal agenesis, Potter sequence. Bronchogenic cysts, caused by abnormal budding of the foregut and dilation of terminal or large bronchi. Discrete, round, sharply defined, fluid-filled densities on chest X-ray, air-filled if infected. Generally asymptomatic, but can drain poorly, leading to an airway compression for recurrent respiratory infections. Okay. We'll go down to club cells. Club cells, microciliated, low columnar/cuboidal with secretory granules located in bronchioles, degrade toxins, P450, secrete surfactant-like component, progenitor for club and ciliated cells. So just bear in mind club cells, which I think were called Clara cells, if I'm not mistaken. Let me just check. Clara cells. Yeah. So Clara, who was Dr. Max Clara, who was canceled by the woke mob for being an NSDAP member and experimenting on, I think, executed prisoners or something like that. Anyway, so he was. They did a little bit of a name change on that one, but it was previously Clara cell. It's now called a club cell. And the important thing is, it says surfactant-like component. What they really mean in that case is that it's not surfactant. It's like surfactant. It's not the same. It's not exactly the same thing. It's a little bit different situation. It's important to be aware that it's similar, but not the actual same thing. A little bit different. Anyway, alveolar cell types. Type 1 pneumocytes. Squamous, 97% of alveolar surfaces, thinly line the alveoli. There's a little A for that, and I'll show you. The thing is right here they're talking about. If you see the picture right here, I don't think you see, it shows here type 1 pneumocyte, type 2 pneumocyte, just bear that in mind. So anyway, so type 1 pneumocytes, squamous, 97% of alveolar surfaces, thinly lined alveoli for optimal gas exchange. And it goes into a little bit of a note section. Pores of Kuhn as in like it's Kohn, like cone or Kuhn. Anatomical communications between alveoli that allow for passing of air, fluid, phagocytes, and bacteria in pneumonia. Type 2 pneumocytes. Cuboidal and clustered, 2 functions. 1. Serve as stem cell precursors for 2 cell types, type 1 and type 2 pneumocytes. Proliferate during lung damage. And then 2. Secrete surfactant from lamellar bodies, arrowheads. It shows the little arrows you can see in that picture again. Application of the law of Laplace in alveoli have increased tendency to collapse on expiration as radius decreases. Okay. So type 2 pneumocytes, those are like the little bit more unique things where they actually are the ones releasing surfactant, and they are like a stem cell precursor. So surfactant decreases alveolar surface tension, decreases collapse, decreases lung recoil, and increases compliance. Important to note, decreases surface tension, increases compliance. Composed of multiple lecithins, mainly dipalmitoyl phosphatidylcholine, DPPC. That's dipalmitoyl phosphatidylcholine. And synthesis begins in 20 weeks of gestation and achieves mature levels at 35 weeks of gestation. Glucocorticoids are important for fetal surfactant synthesis and lung development. Collapsing pressure is equals to surface tension/radius. So collapsing pressure is equal to 2 times surface tension divided by radius. So just keep that in mind. Next is alveolar macrophages. Phagocytose foreign materials, release cytokines, and alveolar proteases. Hemosiderin-laden macrophages may be found that is to say, pulmonary edema and alveolar hemorrhages. You might find them. And I think it says alveolar macrophages are called dust cells. Now, if you have these macrophages that have tons and tons of iron in them in the lungs, those are called heart failure cells, if I'm not mistaken. I could be mistaken on that one. Let me just go check. There's 2 different names for that. Heart failure cells. Yeah, hemosiderin-laden macrophages are called heart failure cells. That's a great thing to have, right? Not exact. It's kind of a telltale sign, basically. In particular conditions, they bring up things like pulmonary edema, alveolar hemorrhages. You might start seeing problems like that with these kinds of cells hanging around. Next, neonatal respiratory distress syndrome. Surfactant deficiency leads to an increase in surface tension, leading to alveolar collapse, a ground glass appearance of lung fields. There's a couple different things that have a quote-unquote ground glass appearance. Make sure you don't confuse them. Risk factors: prematurity, diabetes during pregnancy due to an increase in fetal insulin, C-section delivery, a decrease, which is because of the decreased release of fetal glucocorticoids, less stressful than vaginal delivery. Yeah, so basically what they're saying is the increase in fetal insulin can cause it, which you would have in the case of prenatal or in case of gestational diabetes, I think. Yeah, gestational diabetes. And also if you have a lower level of fetal glucocorticoids when you have a C-section, because there's just less stress involved, theoretically, right? Treatment: maternal glucocorticoids before birth, exogenous surfactant for infant. Okay. Therapeutic supplemental oxygen, retinopathy of prematurity, intraventricular hemorrhage, bronchopulmonary dysplasia, RIB. So that's a way to remember the therapeutic supplemental oxygen, retinopathy, intraventricular hemorrhage, bronchopulmonary dysplasia. Persistently low O2 tension means there's a risk of PDA. Screening tests for fetal lung maturity, lamellar body count, and lecithin sphingomyelin L/S ratio in amniotic fluid. Greater than 2 is healthy, less than 1.5 is predictive of neonatal respiratory distress syndrome, or NRDS. Foam stability index, surfactant albumin ratio. As you can see, that kind of chart right there between the concentration versus gestational age and that kind of thing. Now we're talking about the anatomy. Let me take a short break. Okay. Let's get back into it. Respiratory anatomy, respiratory tree. So the conducting zone, large airways consist of nose, pharynx, larynx, trachea, and bronchi. Airway resistance highest in the large to medium-sized bronchi. Small airways consist of bronchioles that further divide into terminal bronchioles, large numbers in parallel, least airway resistance. Warms, humidifies, and filters air, but does not participate in gas exchange, leading to an anatomic dead space. Important distinction. Cartilage and goblet cells extend to the end of bronchi. Pseudostratified ciliated columnar cells primarily make up epithelium of bronchus and extend to the beginning of terminal bronchioles, then transition to cuboidal cells. Clear mucus and debris from lungs, mucociliary escalator. Airway smooth muscle cells extend to end of terminal bronchioles, sparse beyond this point. Respiratory zone. Okay. Lung parenchyma consists of respiratory bronchioles, alveolar ducts, and alveoli. Participates in gas exchange. Mostly cuboidal cells in respiratory bronchioles, then simple squamous cells up to alveoli. Cilia terminate in respiratory bronchioles. Alveolar macrophages clear debris and participate in immune response. And then we have this little chart right here, which is fun. You can go take a snippet of that if you want to and add it to your notes or whatever. Conducting zone, right, and respiratory zone. So it's 2 different zones major zones are conducting zone and respiratory zone. The conducting zone is the area where air is just passing through. It's just an airway, So we got the trachea, the bronchi, the bronchioles, the terminal bronchioles, and then eventually we transition to the respiratory zone, and we have the respiratory bronchioles. It's the terminal bronchioles before, and then respiratory bronchioles, and then the alveolar sacs. Now, what distinguishes the respiratory zone from the conducting zone is the fact that they actually have gas exchange. So bear that in mind. Respiratory bronchioles, you think, oh, well, that's kind of in the same camp as the terminal bronchioles and the bronchioles and bronchi or whatever. And the answer is kind of, but not really. In terms of its physiological function, respiratory bronchioles are more similar to alveolar sacs in as much as a gas exchange is occurring there when it's really not occurring in the other kinds of bronchioles. But you can just look at that right here and kind of get a good understanding of where things are. And then you can see the club cells in the terminal bronchioles. You can see the type 2 pneumocytes in the alveolar sacs. You can see the bronchioles have ciliated cells and club cells again. I guess you could say that the respiratory bronchioles are more similar, that they have club cells as opposed to having, and their actual histology is more similar, right? That's a fair point. But their actual physiological function is still has the gas exchange component, in all fairness. But the real serious stuff that's used for gas exchange is the alveolar sacs and alveoli themselves, to be fair. Lung anatomy. Your PDF here says lung relations, okay. But regardless, right lung has 3 lobes. Left has less lobes too, and lingula homologue of right middle lobe instead of the middle lobe. Left lung has a space occupied by the heart. The best way to remember that, by the way, is just knowing what side does the heart lay on. Is it the right side or the left side? 99.9% of people, vast majority of people have a left-sided heart that's normal. And as a consequence of that heart being on the left side, the lungs have to make room for it. And as a consequence, there's only 2 lobes of the lung on the left side. And there is a lingula that kind of fills up that little gap, I think, below the heart. As you can see the diagram right there. Yeah, in fact, your book has a better diagram than my book does on that. It's basically what would be the analogous portion of the middle lobe of the lung. It's much smaller, obviously. But the whole point, what I'm trying to communicate in that situation is that just be aware of how the anatomy of the heart works, and then think about, okay, well, which side will have the one less lobe? Probably the one that has the heart in it, Anyway, relation of the pulmonary artery to the bronchus at each lung hilum is described by Rawls, right anterior, left superior. So the way I remember it is, in fact, Rawls. You can say, what does Rawls even mean? It doesn't mean anything. It's just an act. There's no. I honestly. I honestly use Rawlsy. I honestly use that. Never played the game, but I honestly use that one. I guess that'd be Deltarune character, the little goat dude. Yeah, it's RALS. That's what I use. That's also an anagram of I think of that is an anagram of something, isn't it? It was an anagram of Israel, I think, right? Rawlsy is not. Rawls is not, but it doesn't matter. Rawls, right anterior, left superior. To me, it's really kind of a silly thing to harp on, like, oh, who cares which side is which? But they do care about it, so bear that in mind. Right one is the anterior one, left one is the superior one. So when you do a carve out of it, so you look at the lung, you say, okay, look at these little vessels going in and out. Like, what are these things? You say, which one is is this the left side or the right side? And you have to figure out, oh, this is where the actual artery, this is the artery, this is the vein, this is whatever. And you can figure out which side it's on and what's what, that kind of thing. Orient yourself. So remember, right anterior, left superior for each lung hilum. The carina is posterior to ascending aorta and anteromedial to descending aorta. Right lung is more common site for inhaled foreign bodies because right main main stem bronchus is wider, more vertical, and shorter than the left. If you aspirate a peanut while you're lying down while supine, right, usually enters a superior segment of the right lower lobe or sometimes enters a posterior segment of a right upper lobe. If you're laying on your right side or prone, usually enters the right upper lobe. And if you're doing it upright, usually enters the right lower lobe. So if you're standing upright, it just goes down to the bottom lobe of the right side. If you're laying prone, it might go to the right side but the upper lobe. And if you're laying down on your back, usually enters the superior segment of the right upper lobe, or sometimes enters the posterior segment of a right upper lobe. So it's kind of like logically speaking, it's what you would expect. But just remember that the right one is what's going to typically happen to it. It's going to be the right side normally. Thoracentesis. Pleural space between the visceral and parietal pleura. Thoracentesis, remove liquid of air from the space. Needle above the rib. Avoid neurovascular bundle below each rib. Avoid below the 9th rib, where you have a risk of injuring abdominal structures, i.e. the right hepatic lobe and spleen. So you have a little bit of a nice picture in there as well. And you can see but they don't really have good labels for this, do they? Well, they have a carina. They mentioned the carina, but you could just look at that if you want to. There's a diaphragm structure right here. The way I remember it is vea. So vea, the way I would remember is this. You have vea would be T8 is T8, T10, T12 in vea. So T8 would be the IVC, V, right? The inferior vena cava. T10 would be the esophagus, that's the E. And then the A would be the aorta, so that's the A. So vea, V-E-A, T8, T10, T12. There's other structures that go out T8, 10, and 12 too. So they say, okay, see, IVC at T8, also the right phrenic nerve. Okay, sure. T10, esophagus, okay. But also the vagus nerve, which is the pericranial nerve 10. So 2 trunks, okay. And T12 is the aorta, red, okay. Thoracic duct, white. So there is some stuff, azygos vein blue, A-T12, it's the red, white, and blue. Okay, sure. I always remember vea, and I just remember that IVC at T8, esophagus at T10, and the aorta at T12. Those are the more common questions. They might ask about right phrenic nerve, which is also 8. The vagus nerve, it's CN10, so remember it's at 10, T10, crossover. And then 12, you also have the thoracic duct. It might be worth it to make a slide for that for yourself on like an Anki card, a Quizlet card, a PowerPoint quiz, whatever you want to do for that. Diaphragm innervated by C3 through C5, phrenic nerve. Remember, C3 through 5 keeps the body alive. Phrenic nerve for the diaphragm. Pain from diaphragm irritation can be referred to the shoulder, C5, and the trapezius ridge, C3 and C4. Phrenic nerve injury causes elevation of the ipsilateral hemidiaphragm on X-ray. So if you have a nerve damage there, it can cause, of the phrenic nerve, it can cause elevation of the same side hemidiaphragm on rib X-ray. So they have their own little number thing is here. So T8 vena cava I, T10 esophagus, because it's like a older archaic spelling with an O before esophagus. And then T12 aortic hiatus. So I 8, 10 eggs at 12. C3, C4, C5 keeps the diaphragm alive. Okay. Other bifurcations, the common carotid bifurcates at C4. Haha, that's so funny. The trachea bifurcates at T4. Okay, and the abdominal aorta bifurcates at L4. That's not a bad one. I've not heard that one before. Well, actually, I have heard of it. I just forgot about it when I read this the first time. Common carotid bifurcates at C4. Trachea bifurcates at T4, and the abdominal aorta bifurcates at L4. Cool. On to the next section. Line thing says physiology. Okay. Respiratory physiology. Lung volumes and capacities. There are 4 volumes and 4 capacities. Note, a capacity is a sum of greater than 2 physiologic volumes. Tidal volume. So the order is a little bit different, I think, in this case. Or maybe it isn't. It's slightly different. Tidal volume. Air that moves into the lung with each quiet inspiration. 6 to 8 milliliters per kilogram, typically 500 milliliters. Inspiratory reserve volume. Air that can still be breathed in after a normal inspiration. So it's like after you take a normal breath, how much more air can you get into your body after that if you exert yourself a bit? Expiratory reserve volume. Air that can still be breathed out after a normal expiration. So again, if your tidal volume is like your normal breathing cycle, and inspiratory reserve and expiratory reserves are like how much further can you go with it beyond what you would do under normal circumstances. Residual volume. Air in the lungs after maximal expiration. Residual volume and any lung capacity that includes residual volume cannot be measured by spirometry. That is true. So basically the idea is if you breathe out as much as you can, what air is still left? That's called residual volume. And it's really, you can't measure it directly because you can't get the air out, It's a little bit more complicated. Inspiratory capacity. There's other methods that don't involve the spirometer necessarily, but it is not the spirometry itself. Normal spirometry will not measure that. Inspiratory capacity. IRV plus VT. I think that's supposed to be inspiratory reserve volume plus tidal volume equals inspiratory capacity, which is air that can be breathed in after a normal exhalation. So you breathe out. Breathe out for me, please. And take a full breath in, as much as you can. That change in volume, that's called the inspiratory capacity. It's both the normal breath in and the full breath. It's like a full breath in after expiring. After a normal expiration, I think. Yeah, functional residual capacity is reserve volume plus expiratory reserve volume. Sorry, residual volume plus expiratory reserve volume. Volume of gas in lungs after normal expiration. Outward pulling force of chest wall is balanced with inward collapsing force of lungs. So basically, functional residual capacity is how much air is in your lungs after a normal expiration. Vital capacity is the inspiratory reserve volume plus the expiratory reserve volume plus the tidal volume. That's basically maximum volume of the gas that can be expired after a maximum inspiration. So basically, the total range of volume differences, that's the vital capacity. You take a full breath in, and then you take a full breath out. That is the vital capacity. It's maximum effort in both ends, both expiring and inspiring. How much air changes there? How much volume difference is there? Total lung capacity is the inspiratory reserve volume plus the tidal volume plus the expiratory reserve volume plus the residual volume, which equals the vital capacity plus the residual volume. That's correct. It's basically it's everything. Volume of gas present in lungs after maximal inspiration. And that includes the residual volume that you can't get out of your lungs. Again, this would be probably a little bit more difficult to measure because you cannot use a spirometer under normal circumstances to measure that. A spirometry wouldn't measure that typically, right? Because it's including all that air that stays in the lungs even after a maximum expiration. There's a little chart on there as well that kind of give you a perspective of how these things are compared, or how these things kind of look, if you will. The termination of let me read this. Work of breathing. Work of breathing refers to the energy expended or O2 consumed by respiratory muscles to produce the ventilation needed to meet the body's metabolic demand. Combination of flow resistive and elastic work, i.e. work equals force times distance equals pressure times volume, needed to overcome both elastic recoil and airway resistance. Minimized by optimizing respiratory rate, RR, and tidal volume. Increase in restrictive diseases. Increased work to overcome elastic recoil resistance achieved with increase in respiratory rate and decrease in tidal volume. And obstructive diseases. Increase in work to overcome airway resistance achieved with decrease in respiratory rate and increase in tidal volume. The termination of physiologic dead space. VD, which I would assume is the dead space volume. Yeah, physiologic dead space, okay. Equals tidal volume times PaCO2 minus PeCO2, all divided by PaCO2. And you have that same little thing right there as well. So VD, physiologic dead space, equals anatomic dead space of the conducting airways plus alveolar dead space. So wait, VD, physiologic dead space, which equals the anatomic dead space of conducting airways plus alveolar dead space. Apex of healthy lungs is largest contributor to alveolar dead space. VD equals volume of inspired air that does not take part in gas exchange. That's a good way to define it. PaCO2 is arterial PCO2. And PeCO2 is the expired PCO2. So basically, what's the change between the arterial and the expired divided by the arterial PCO2? So physiologic dead space, approximately equivalent to the anatomic dead space in normal lungs, may be greater than anatomic dead space in lungs with ventilation perfusion mismatch. So what it's saying is that there's going to be an anatomical dead space regardless. So for example, when you breathe in, your conducting airways don't actually have areas for gas exchange. So the air that's still present there during gas exchange will not exchange gas because there's nothing going on there. It's not physiologically viable to have gas exchange there, right? It's not designed to do that. And so that's considered an anatomic dead space. Your bronchi are anatomic dead space, for example. Your trachea is anatomic dead space. However, you could have alveolar dead space, which is not necessarily it's not anatomical, right? It might be because of some sort of a ventilation perfusion issue. You know, you might have, let's say, in the upper lungs, less blood in your upper lobes of lungs, and so you might have less ability to exchange gas appropriately. Or maybe there's maybe there's some sort of issue of a disease nature where you can't properly exchange gas in certain places of your lungs, or maybe systematically. So that's more of an issue. That's a physiological issue in that case when it comes to alveolar. Although in this case they're defining both anatomic and alveolar dead space as being in combined the physiological dead space. Okay. So my book is again a little bit different. My thing is talking about ventilation a little bit first off, and then we transition over into, here we go. Okay. Ventilation. Minute, or is it minute ventilation or minute ventilation? Anyway, so ventilation, VA equals VE minus VD, which I think what that is we're just talking about the dead space and stuff like that as well, VD, so forth. But let's see, so VA equals VE minus VD. Minute ventilation, abbreviated as VE, total volume of gas entering and exiting the lungs per minute. VE equals VT times respiratory rate. So tidal volume, is that tidal volume? I believe so. Yeah, tidal volume times respiratory rate gives you the minute ventilation. Alveolar ventilation, abbreviated as VA, total volume of gas that reaches alveoli each minute. So VA equals tidal volume minus dead space, all multiplied by the respiratory rate. And normal respiratory rate is about 12 to 20 breaths per minute. The tidal volume is usually about 500 milliliters per breath, and the dead space is usually about 150 milliliters per breath. Lung and chest wall properties. Lung inflation follows a different pressure volume curve than lung deflation due to the need to overcome surface tension forces during inflation. Hysteresis. Differences between pressure of inhalation, volume increasing, and pressure of exhalation, volume decreasing. Because of the historical reasons at small pressures, pulmonary pressures are always presented in CmH2O. So there's a little chart right here that I don't think you have, but it's just showing the lung volume change versus alveolar pressure, CmH2O, and the intrapleural pressure, CmH2O, and just showing the tidal volume versus the FRC. Elastic recoil. Tendency for lungs to collapse inward and chest wall to spring outward. At FRC, which is the functional residual capacity. At functional residual capacity, airway and alveolar pressures equal atmospheric pressure, PB called zero, and intrapleural pressure is negative, preventing atelectasis. The inward pole of the lung is balanced by the outward pole of the chest wall. System pressure is atmospheric. Pulmonary vascular resistance, PVR, is at a minimum. Okay. So the chest wall wants to spring outward, but the lungs themselves want to collapse. Interesting. Compliance. We were talking about compliance before about surfactant. Compliance, change in lung volume for a change in pressure. dV, or I should say delta V divided by delta P, inversely proportional to wall stiffness and increased by surfactant. Inversely proportional to wall stiffness. The more stiff it is, the less compliant it is. And the less compliant, the more stiff, right? If it's stiff, that implies it's not very flexible, right? It's not willing to comply to changes in volume. So if I'm trying to blow up a balloon, for example, and I'm putting a lot of pressure in the balloon, I'm putting a lot of oxygen or whatever air, it gets the carbon dioxide, nitrogen, whatever is in the air, in the balloon. If the balloon is very stiff, it doesn't want to change its volume. It might have a pressure increase. Let's say it has identical pressure, but it doesn't really want to increase its volume at all because it's stiff. Conversely, the balloon is very, very compliant, then it'll be readily willing to expand in accordance to this new change in pressure. Increasing compliance equals lungs easier to fill, that is to say, like in emphysema or older adults. A decreased lung compliance, lungs are more difficult to fill, for example, in pulmonary fibrosis, pneumonia, ARDS, and pulmonary edema. There's a lot of conditions that cause lower compliance, although there are some conditions like emphysema in older adults where they might have a higher compliance. In those cases, though, I would say that part of the reason is that they don't have as much recoil. If I'm not mistaken, I could be mistaken. I think I'm correct on that one. And so the lungs are just almost like permanently inflated. So for example, people who are smokers, they will have a permanently enlarged barrel chest over time as a consequence of their habits, essentially. And it won't want to recoil back to its original position. It'll just be hyperinflated. So I'm going to take a short break again. Okay, so we're back. Let me go back into the page I'm probably supposed to be on now. Pulmonary circulation. Wow, they're really moving things around in this book. So I'll read as according to how my book lists things out, and I might have to go a few pages back when I get back to that section. Pulmonary circulation. Normally, a low-resistance, high-compliance system, A, decreases in PaO2, which is arterial oxygen, causes hypoxic vasoconstriction that shifts blood away from poorly ventilated regions of the lung to well-ventilated regions of the lung. Perfusion limited, O2, normal health, CO2, N2O. Gas equilibrates equally along the length of the capillary. Exchange can be increased only if blood flow increases. Diffusion limited, oxygen, emphysema, fibrosis, CO. Gas does not equilibrate by the time blood reaches the end of the capillary. O2 diffuses slowly, while CO2 diffuses very rapidly across the alveolar membrane. Disease states that lead to diffusion and limitation, for example, pulmonary fibrosis, are more likely to cause early hypoxia than hypercapnia. That is true. So remember, hypoxia is more likely to pop up before you have hypercapnia necessarily. And there's a second section, part of it. Chronic hypoxic vasoconstriction may lead to pulmonary hypertension plus or minus cor pulmonale. True. And the reason is because your body is going to want to, in some cases, say, oh, hypothetically what's going to happen is, like, let's say this is part of your lungs that are, let's say they're not getting a lot of oxygen, it's not fair, it clearly shows as dysfunctional. The body will vasoconstrict that particular area so that more blood can go to the areas that are more, basically well saturated and better able to do gas exchange. And that's a way to improve efficiency. However, if everything is bad at it at the same time, everything gets vasoconstricted, and that actually causes a pulmonary hypertension, which then can cause right heart failure. Diffusion, J equals A times dk times P1 minus P2 over delta X, where the A is area, delta X is the alveolar wall thickness, dk is the diffusion coefficient of gas, P1 minus P2 equals difference in partial pressures, A decrease in emphysema, and delta X increase in pulmonary fibrosis. Okay, so you have a decrease in the area when you have emphysema, fair enough, and you have an increase in the alveolar wall thickness in pulmonary fibrosis. True. DLCO is the extent to which CO passes from the air sacs of lungs into the blood. And I have a chart here, and you have your own charts right there as well, showing equilibration, partial pressure, fibrosis diffusion limited, PA CO2 perfusion limited, and then the diffusion limited for PaCO. Now, going back into the earlier part talking about the hypoxic vasoconstriction, I think I kind of touched on that. Basically, the body says, oh, this area is not getting enough oxygen, it's bad at actually doing gas exchange, we'll do a vasoconstriction there, and that'll increase blood flow to other areas. That works as long as it's a particular location that has an issue. If everything's messed up, though, it's a recipe for disaster, basically, in pulmonary hypertension. Pulmonary vascular resistance. Let me see if I can find anything on this, because it feels like everything is out of place. Here we go. Pulmonary vascular resistance. PVR equals P, pulmonary artery, minus L, P, L atrium, left atrium, all over Q, which is cardiac output. Q with a little dot on top of it, cardiac output. Remember, delta P equals cardiac output times resistance. So resistance equals what is delta P in this case? Is that change in pressure? No, I don't think so. Let's see. Did we define it before? Let me see. Delta P. Delta P, I'm not seeing anything off the top of my head, but regardless, delta P equals cardiac output times the resistance. So resistance equals delta P divided by cardiac output. I guess that would be pressure. Yeah, I guess I think that would be pressure. Or change in pressure. Resistance equals 8 times viscosity of blood. I would, if I were you, I would just check that, just make sure. But resistance equals 8 times viscosity of blood times the vessel length, all divided by pi times radius to the power of 4. Okay. Well, I guess they really trimmed down this section, or they trimmed down some of the stuff, but maybe they reorganized it, I'm not sure. But here we go, ventilation perfusion. Ideally, ventilation V is mismatched to perfusion Q per minute, i.e. the VQ ratio equals 1 for adequate gas exchange. Lung zones. VQ at apex of lung equals 3. Waste of ventilation. Too much ventilation, not enough perfusion. VQ at base of lung is 0.6. Waste of perfusion. That is to say, there's a lot of perfusion going on, not enough air. And I'm not mistaken, there might be 2 factors involved in that, but I think the biggest one is just the blood availability. So like, for example, the amount of blood available in the top part of the lung, because of how gravity works, is just less. There's just less blood available in the top part of the lung because of because of how gravity works, and so you will just have a VQ mismatch where you will have more ventilation than you know what to do with, basically, because the blood just isn't there compared to what you see in the lower lungs, where the blood wants to go to, because again, gravity has its own impact on your cardiovascular system. So think about that too in other situations as well. Think about the fact that your heart has to pump hard enough to get blood to your head, to get blood to any part of the body that's above the heart. Not to mention the fact that when blood goes goes below the heart into your abdomen, into your legs, and so forth, the blood has to get back up to the heart somehow. So it's kind of an interesting process, and it does have an impact. Gravity has a real world impact on your cardiovascular system, certainly. Both ventilation and perfusion are greater at the base of the lung than at the apex of the lung. With exercise, increasing cardiac output, there is a vasodilation of the apical capillaries, so the VQ ratio approaches 1. Okay. Certain organisms that thrive in high oxygen, as I say TB, flourish in the apex. So what they're saying is basically a similar point, but I think they're more accurate than I was, that actually the lower part of the lung has more ventilation than the top part of the lung. They say both ventilation and perfusion are greater at the base of the lung than at the apex of the lung. So they're saying the reason that we have a VQ mismatch where there's ventilation wasted in the top part of the lung is not because there's so much ventilation in terms of raw numbers, is actually less of it compared to the base of the lung. The reason is that the top of the lung has less blood, where the bottom of the lung has a lot of blood. And so there's more blood than they know what to do with in the bottom of the lung. And there's not enough blood in the top of the lung, and so that's why you have that VQ mismatch. It's basically, not only is it a consequence of of blood availability, but it goes beyond 100%. So to give an example, we talk about, let's say, the genetics versus environmental considerations, nature versus nurture. We might say, 60% of variation in height, let's say 80% of variation in height in the United States is genetic and 20% is environmental. That is to say, if you had a random, say hypothetically, you had a random person, and you said there's a gap between these two people of, let's say, 2 inches, then we could say, theoretically, on average, 80% of that gap is going to be because of a genetic difference, and 20% is going to be an environmental difference. In this case, though, it's not that the blood differential is responsible for 80% of the difference and the ventilation is responsible for 20% of the difference. No, it's that blood difference is more than 100% because the ventilation is actually in favoring the base of the lung, but nevertheless has not enough ventilation. Even though the base of the lung has more ventilation than the top of the lung, even though that's true, it's still not enough to compensate for the situation in any meaningful way. It's more than 100% of the gap, funnily enough, is actually caused by the blood differential, which is interesting. I don't know how much better the ventilation is. It's just that it's known to be at least somewhat better, I guess. VQ, and by the way, the mismatch does improve when you have, as we were talking about before, with exercise, because you have an increased cardiac output. That'll help improve blood availability in the apex of the lung and help kind of smooth things out a little bit. VQ equaling zero Eulerway, if you replace the A with an O, Eulerway. Obstruction, shunt. In shunt, 100% of O2 does not improve. PaO2, that is to say foreign body aspiration. Yeah, so basically when the VQ is 0, think about a shunt, think about a foreign body aspiration, because in that situation, there just isn't any ventilation going on. So if V is 0, then V over Q is 0. And what that means is that you just can't get ventilation. Why won't you have ventilation? Probably because you have something blocking access to new air, or the exchange in the first place of air. You can't get air into your body. What if VQ is approaching infinity? Then it's blood flow obstruction, physiologic dead space. So assuming less than 100% dead space, 100% oxygen improves PaO2, pulmonary embolus. So in that case, if you have a situation where if you actually have a blood perfusion issue, blood flow obstruction, that's a physiologic dead space, of course, rather than a issue of oxygen per se. Assuming less than 100% dead space, though, you can use 100% oxygen to improve that situation in a way that would not be useful if you had an obstruction of a foreign aspiration or something like that. So just keep that in mind. And you can see that diagram that you have in here as well. Now I have an alveolar gas equation. I think it's probably higher up. Here we go. I don't know why this is organized a little bit differently. Alveolar gas equation. PaO2 equals PiO2 minus PaCO2 divided by RQ. RQ is the respiratory quotient, which is also the CO2 produced divided by the O2 consumed. That equals about 150 mmHg minus PaCO2 divided by 0.8 at sea level breathing room air. Okay. Next page is on that big red blood cell. Carbon dioxide transport. Majority of CO2, 90%, must be converted to bicarb, or sorry, HCO3 minus. I'll make sure that I'm not saying this incorrectly. Yeah, that's bicarbonate. Okay. Just want to confirm. Majority of CO2, 90%, must be converted to bicarbonate in RBCs. 1. Carried in the plasma to the lungs and released via the carbonic anhydrase reaction. CO2, 5%, also binds to various plasma proteins, carbamino protein compounds, including the N-terminus of the globin in deoxygenated hemoglobin in RBCs, carbaminohemoglobin or HbCO2. 2. Small percentage of CO2, 5%, can be dissolved into plasma itself. 3. So what they're saying is the vast majority of CO2 in your blood is going to be converted into bicarb. Okay, someone's going to be brought up into these RBCs, I believe. Yeah, including the what's this here? Binds to various plasma proteins, including the ones of the RBCs. And the third part is it just dissolves into the plasma. Now, if you had a situation, let's say for example, where you had no ability to convert to bicarb, and you had no ability to bind it to red blood cells, you really wouldn't have as much of ability to really transport carbon dioxide very effectively out of the body or around the body. That ability to use bicarb is really a huge, of great utility, basically. In the lungs, hemoglobin oxygenated promotes dissociation of hydrogen ions, leading to an equilibrium shift towards CO2 production, leading to a CO2 is released from RBCs. Haldane effect, and that sounds like it's related to. It sounds like it's related to the Bohr effect a little bit, but I guess it's technically something different. The main point, though, is that if you have oxygenated RBCs, it promotes that shift basically in the release of the RBCs of the CO2 from RBCs. So when hemoglobin is oxygenated, it promotes dissociation of the hydrogen ions and shifts equilibrium towards CO2 production, leading to CO2 release from RBCs. Okay. Now let's talk about hypoxia and hypoxemia. Is that up here or is it down there? Let me see. I'm not seeing it. I don't know what's going on with this. I see my hemoglobin section. I wish it was just a little bit more consistent how they order things. I'm not sure. That's kind of a funny thing. Oh, we have this new version of the textbook. Oh, what does it have? Oh, we reorganized it a little bit. Okay, cool. Anything else? Well, you have to find out, so. I'll just go to the hemoglobin one because I know I have this section right after this one. So the hypoxia and hypoxemia. This is basically a diagram with a couple different things to look at. Hypoxia, decrease in O2 delivery to tissues, commonly due to a decrease in cardiac output. Hypoxemia, insufficient oxygenation of blood with decrease in PaO2. Ischemia, anemia, or CO cyanide/cyanide poisoning. So carbon monoxide versus cyanide poisoning. So these things as well can cause issues. So there's 5 points. Let me go through 1 through 5. And hypoxemia, by the way, hypoxemia is insufficient oxygenation of the blood. So when we say hypoxia, we are saying low oxygen. When we say hypoxemia, we're saying low oxygen of the blood. The think about aima, like from the Greek, aima, that refers to the blood. So let's talk about it. 1. What were these causes of hypoxia? What would cause hypoxia? 1. Decrease in inspired oxygen tension, PiO2. PiO2 equals FiO2 times Pb minus H2O, most commonly due to a decrease in Pb in high altitude. Okay. 2. Hypoventilation due to an increase in PaCO2. PaO2 equals PiO2 minus PaCO2 divided by RQ, that is to say CNS depression from opiate overdose, obesity, hypoventilation syndrome, neuromuscular weakness. Okay. 3. Diffusion limitation, that is to say fibrosis. And 1 and 2, we said inspired oxygen tension is decreased or hypoventilation due to an increase in PaCO2. Those are examples of normal AA gradient. But now we're going to talk about, when we talk about 3 and onward, we're talking about a increased AA gradient, an alveolar arterial, I think, gradient is what I believe they're referring to. So 3, diffusion limitation, that is to say fibrosis. 4, VQ mismatch, normal perfusion, edema, or a decrease in perfusion in areas of normal ventilation, that is to say pulmonary embolism. 5, right to left shunt, the extreme of VQ mismatch. Normal perfusion in areas of no ventilation can be anatomic, that is to say intracardiac shunt, or physiologic, that is to say perfusion of non-ventilated alveoli and ARDS. So 4 and 5, 4 is VQ mismatch, 5 is right to left shunt, which is an extreme of VQ mismatch, and also we have diffusion limitation, just like you can't get oxygen. You have like fibrosis, basically, something like that. Let's talk about hemoglobin. Hemoglobin, normal adult hemoglobin, HB, is composed of 4 polypeptide subunits, 2 alpha and 2 beta, that each bind one O2 molecule. Hemoglobin is an allosteric protein that exhibits positive cooperativity when binding to O2, such that oxygenated hemoglobin has a high affinity for O2, 300 times, and deoxygenated hemoglobin has a low affinity for oxygen, promotes release and unloading of O2. The protein component of hemoglobin acts as a buffer for hydrogen ions and CO2. Myoglobin is composed of a single polypeptide chain associated with one heme moiety, higher affinity for oxygen than hemoglobin, essential for full oxygenation of aerobically active muscle. And your book here in the PDF says hemoglobin acts as a buffer for hydrogen ions. Fair enough. And it also talks about the other kinds of hemoglobin, which is relevant as well. Fetal hemoglobin, 2A, 2 alpha, and 2 gamma subunits has a higher affinity for oxygen than the adult hemoglobin, driving diffusion of oxygen across the placenta from mother to fetus. An increase in O2 affinity results from the decrease in affinity for the fetal hemoglobin for 2,3 BPG. And when you study thalassemias, you'll have to know which subunits are messed up with in that case as well, and also with sickle cell disease. But we're not going to get into that here necessarily. You can look more into that if you want to learn about sickle cell hemoglobin and stuff like that. What's going on with that? Then we're talking about oxygen content of blood, and then the oxyhemoglobin dissociation curve. So we have that going on right here, and we have this stuff about methemoglobin here. Not sure exactly where my particular section is, but oxygen content of blood. O2 content equals the O2 bound to hemoglobin plus the O2 solubilized in plasma equals 1.34 times hemoglobin times SaO2 plus 0.003 times PaO2, where SaO2 is the percent saturation of arterial blood with O2, 0.003 is the solubility constant of O2, PaO2 is the partial pressure of O2 in arterial blood. Normally, 1 gram of hemoglobin can bind 1.34 milliliters of oxygen. Normal hemoglobin amount in blood is 15 grams per deciliter, or deciliter. Deciliter? I'm not quite sure. DL. Little dl. O2 binding, carrying capacity, about 20 milliliters, O2 divided by dl of blood. With decrease in hemoglobin, there is a decrease in oxygen content of arterial blood, but no change in O2 saturation and PaO2. O2 delivery to tissues equals the cardiac output times O2 content of blood. So hemoglobin concentration, and there's a little chart right here that says, hemoglobin concentration, SaO2, PaO2, and total O2 content. So for carbon monoxide poisoning, CO poisoning, normal hemoglobin concentration, a decrease in SaO2 because of the carbon monoxide competes with the oxygen. The PaO2 is normal, but there's a decrease in overall O2 content. In anemia, there's a decrease in hemoglobin concentration, obviously. There is a normal SaO2, there is a normal PaO2, but there's a decrease in O2 content in total. In polycythemia, there's an increase in hemoglobin concentration, obviously. There is a normal SaO2, a normal PaO2, and an increase in total oxygen content. Methemoglobinemia, there's a normal hemoglobin content, a decrease in SaO2 because the iron 3 plus has a poor at binding and oxygen. And you have a normal PaO2 and a decrease in total oxygen content. Cyanide toxicity has a normal hemoglobin concentration, a normal SaO2, a normal PaO2, and actually normal O2 content as well. I'm a little bit surprised by that. But just for reference, a lot of these, basically everything is going to cause that's pathological in this case, is going to decrease the total O2 content. Cyanide is apparently normal O2 content, but polycythemia is also an exception because it's obviously more RBC, so you have an increase in oxygen. But everything else, carbon monoxide poisoning, methemoglobinemia, anemia, those are all decreased O2 content. Now I'm talking about the oxyhemoglobin dissociation curve. So the oxyhemoglobin dissociation curve, shifts in oxyhemoglobin dissociation curve, ODC, reflect local tissue oxygen needs. Can be helpful, meets metabolic needs, or harmful in toxicities, pathophysiologic situations. Right shift in the ODC reflects a decrease in hemoglobin affinity for oxygen, leading to an increase in oxygen unloading at tissue. Physiologically, this occurs with an increase in oxygen needs, like exercise, a decrease in pH, an increase in temperature and fever, hypoxia, increase in 2,3 BPG at the cellular level caused by an increase in hydrogen and CO2 created by tissue metabolism, which is the Bohr effect. True. Left shift in ODC reflects an increase in hemoglobin affinity for oxygen, leading to a decrease in O2 unloading in tissues. Physiologically occurs of decrease in O2 needs, like a decrease in temperature. In pregnancy, fetal hemoglobin has higher O2 affinity than the adult, and an increase in O2 binding due to a decrease in affinity for 2,3 BPG, causing a left shift driving O2 to cross the plasma of the fetus. pathologically occurs with increase in increase in CO, more carbon monoxide, increase in methemoglobin, genetic mutations causing a decrease in the 2,3 BPG. Left is lower. So, the best way I can phrase this is this. When you have a right shift, the right is more greedy with the oxygen. When the hemoglobin is right shifted, it is greedy with the oxygen. It doesn't want to get rid of it. Oh, I'm sorry, I reversed it, sorry. Right shift in ODC reflects a decreased affinity for oxygen. So I'm wrong. So when it's right shifted, the right shift says we want to get rid of this oxygen. The hemoglobin says we don't want anything to do with this oxygen. We want to get rid of it. And that's a right shift. Right shift is saying we don't want anything to do with this stuff. We want to get rid of the oxygen. And there's a decreased affinity for the oxygen. So that would be like in higher temperatures, when there is lower oxygen available in the area, there's lower oxygen concentration. And I believe they said, what else was it? At lower pHs, when it's more acidic, when you have more acid, higher temperatures, and lower oxygen availability, the red blood cells experience this thing that say, we want nothing to do with this oxygen, we want to get rid of it as much as possible. That's a right shift. Right shift is when they want to get rid of it, basically. Left shift is when they want to keep everything for themselves. They say, we want to have as much as possible. Left shift happens in the opposite circumstances. So left shift happens when you have a cold temperature. Left shift happens when you have a situation where you have a lot of oxygen available. And that makes sense because, and again, that's when you want to take as much oxygen as possible. So when you're in the lungs, for example, and you have all this oxygen available, the hemoglobin have a high affinity for it. They say, we want to take up all this oxygen as much as possible. But when they get to the tissues, and they're going to these tissues that are oxygen poor, and they're saying, we need to get rid of all this oxygen and give it to the cells. And so it's a very, very useful situation where when the body needs oxygen, the hemoglobin of the blood cells will get rid of it and give it to the cells that need it, basically. And when they're in the lungs, when they have lots of oxygen and are plentiful, they take up the oxygen. So it's very useful in that sense. The ODC, which is again the oxyhemoglobin association curve, has sigmoidal shape due to a positive cooperativity. That is to say, the tetrameric hemoglobin molecule can bind 4 O2 molecules and has a higher affinity for each subsequent O2 molecule bound. Myoglobin is monomeric and thus does not show positive cooperativity. Thus, curve lacks sigmoidal appearance. So myoglobin, as you can see, does not experience that effect. But the actual hemoglobin itself, every time it binds to an oxygen, it becomes more and more, has higher and higher affinity for it until obviously it has no ability to bind to anything more. So the first one is kind of tough. The second one is better. Third one is even more affinity. And fourth one is the greatest affinity to bind to that fourth one. But after that, it can't bind to anything more. Response to high altitude. Let's see if we can find that section. Here we go. Okay. Response to high altitude. Constant FiO2, but a decrease in Pb leads to a decrease in atmospheric oxygen, PiO2. This leads to a decrease in PaO2, leading to an increase in ventilation, leading to a decrease in PaOCO2, leading to respiratory alkalosis, which leads to respiratory altitude sickness, which is the headaches, nausea, fatigue, lightheadedness, sleep disturbance. Basically, the best way I can phrase it to you is this. I don't like how they do this whole, this set of numbers and letters and everything else, that this causes this to happen. I would phrase it like this. Let's say you're going up into a mountain, and the mountain has a higher altitude. There's less oxygen available. Your body's going to notice this and say, there's not enough oxygen available. We're going to have to increase respirations to compensate. And so you're breathing more often. But here's a problem. Now that you're breathing more often, you're also letting off carbon dioxide more quickly. And so now you will have a low carbon dioxide content relative to what it normally would be. And because CO2 is involved in regulating your acid-base balance, you will have a metabolic alkalosis, metabolic alkalosis, a respiratory alkalosis, where you have a higher pH, more base, because you're getting rid of all your carbon dioxide because you're having hyperventilation, and you're having hyperventilation because you don't want to have hypoxia. Basically, that's what's going on. And you can treat that with, I think acetazolamide, I believe is the drug we'd use for that. That's going to, it talks about it right here. And that's going to be affecting at the, I like to say the PCT of the kidneys, of the renal system. Proximal convoluted tubule, I believe, is what the acetazolamide acts on. Anyway, chronic increase in ventilation. Increase in erythropoietin, primarily from kidneys, leading to an increase in hematocrit and hemoglobin due to chronic hypoxemia. An increase in 2,3-BPG binds to the hemoglobin rightward shift of oxyhemoglobin dissociation curve, leading to an increase in oxygen release due to increased glycolysis and isomerization by BPG mutase. Cellular changes lead to an increase in mitochondria. Increase in renal excretion of bicarb to compensate for respiratory alkalosis, which can augment with acetazolamide. Chronic hypoxic pulmonary vasoconstriction, leading to an increase in pulmonary vascular resistance, pulmonary hypertension, right ventricular hypertrophy, RVH. Yeah, so what they're saying in this case too is that, the body itself will try to compensate for that respiratory alkalosis by doing a kind of a renal acidosis, basically a metabolic acidosis to compensate for the respiratory alkalosis by trying to get rid of base itself on its own by removing bicarb from the system as well. And you can have a situation where you have vascular resistance increasing because of the lower oxygen availability, so the body starts causing vasoconstriction, and that can cause right heart problems. So, response to exercise: increase in heart rate. An increase in stroke volume leads to an increase in the cardiac output, which leads to an increase in pulmonary blood flow, leading to an increase in VQ ratio from base to apex, becoming more uniform. Increase in cellular respiration, leading to an increase in CO2 production, and decrease in pH at tissues, leading to a right shift of the ODC, causing a tissue offloading of more O2, leading to an increase in O2 consumption, increase in O2 difference in arteries and veins, increase in respiratory rate to meet the increase in O2 demand and remove excess CO2. Increase in pulmonary blood flow. PaO2 and PaCO2 are maintained by homeostatic mechanisms. A decrease in PvO2 due to an increase in O2 consumption. PvCO2 due to an increase in CO2 production. Okay. Let's find methemoglobin. I think that was mentioned before somewhere. That's hemoglobin. Here we go, methemoglobin. Oh, my section is a little bit different, I think. Mine says this: iron in hemoglobin is normally in a reduced state. Ferrous, Fe2, just two of us, so funny. Oxidized form of hemoglobin, ferric, Fe3+, has reduced oxygen affinity, leading to a tissue hypoxia from the decrease in O2 saturation and the decrease in O2 content. Iron also has an increased affinity for cyanide. This oxidized form is called methemoglobinemia. While typical concentrations are 1 to 2%, methemoglobinemia will occur at higher levels and may present with cyanosis. It does not improve with supplemental oxygen and with chocolate-colored blood. Dapsone, local anesthetics, that is to say benzocaine, and nitrites from dietary intake or polluted water sources can cause poisoning by oxidizing Fe2+ to Fe3+. I think you can also get methemoglobinemia from taking certain kinds of medications as well. So, like, I guess it'd be nitric oxide probably, I think has a possibility of causing methemoglobinemia, if I'm not mistaken. I would fact check that one. Methylglobinemia can be treated with methylene blue and vitamin C. Yeah, that is true. Next section is on cyanide versus carbon monoxide poisoning. That's an important thing to be aware of the differences because there's a lot of overlap in how they present themselves, but they are technically different. I mean, they're technically different. They are different origin for why they caught, and there are some things you have to use to figure out which one's which when looking at a patient. Do we have it in here? I don't know. Let's see. I'm not seeing it, honestly. That's too bad. Anyway, cyanide versus carbon monoxide poisoning. Both inhibit aerobic metabolism via inhibition of complex IV or complex IV of ETC, cytochrome or cytochrome C oxidase, leading to a hypoxia that does not fully correct with supplemental oxygen, and an increase in anaerobic metabolism. So how are they distinct? Well, let's see. Cyanide. Cyanide, you're exposed to synthetic product of combustion, amygdalin ingestion, found in apricot seeds, cyanide ingestion in suicide attempts, or on YouTube you have to say something like unalived. He unalived himself. Hermann Goering took a cyanide pill and unalived himself in prison. It's like, yeah, I guess you can call that. I don't know. It was an unaliving attempt. Fire victims. True. Risk of cyanide toxicity with use of nitroprusside in hypertensive emergencies. True. Presentation. Headache, dyspnea, drowsiness, seizures, coma. Skin may appear flushed, cherry red, due to bright red venous blood. Venules in retina appear bright red. Breath may have a bitter almond odor. Labs. Normal PaO2, increase in lactate, leading to an anion gap metabolic acidosis. The effect on oxygen hemoglobin. Cyanide binds to the cytochrome A3 in complex IV, leading to ample O2, but cannot be used due to an ineffective oxidative phosphorylation. Curve is normal. O2 saturation may appear normal initially. How do you treat it? Decontamination, that is to say, remove clothing. 100% O2 is ineffective. Instead, give treatments to remove and excrete the cyanide. Hydroxycobalamin binds the cyanide, leading to cyanocobalamin, which can be excreted renally. Nitrites oxidize hemoglobin, leading to methemoglobin, binds cyanide, cyanomethemoglobin, which decreases toxicity. Sodium thiosulfate, which increases cyanide conversion into thiocyanate, which can be renally excreted as well. So what about carbon monoxide? Well, in case of carbon monoxide from tobacco smoke, furnaces, space heaters, fires, motor exhaust, incomplete combustion of carbon-containing compounds, odorless, tasteless, colorless, non-irritating, leading worldwide cause of death by poisoning. Very, very important thing. It causes presentation will be headaches, vomiting, confusion, visual disturbances, coma, may have cherry red skin with bullous skin lesions, multiple victims be involved, like family due to faulty furnace. So that's another thing. It might be like if your furnace is messed up or something like that. it might be multiple people rather than something like a cyanide tablet or something like that. It's going to be like basically one person or whoever, how many people who consumed them, I would assume in that case. Labs for carbon monoxide. Normal PaO2, increase in carboxyhemoglobin on co-oximetry cannot be distinguished with pulse oximetry, classically associated with bilateral globus pallidus lesions on MRI, although can rarely be seen with cyanide toxicity. Left shift in ODC, leading to an increase in affinity for O2, leading to a decrease in O2 unloading in tissues. Binds competitively to hemoglobin with an increase with a greater than 200 times greater affinity than oxygen to form carboxyhemoglobin, leading to a decrease in O2 saturation on hemoglobin. So how do you treat carbon monoxide poisoning? Give 100% O2 to overcome the increased affinity for CO. Hyperbaric oxygen if severe. CO hemoglobin half-life is 300 minutes, leading to a decrease to 80 minutes on 100% oxygen, leading to a 20 minutes in a hyperbaric O2 chamber. If concurrent CO and cyanide poisoning, as suspected in victims of fire, that sounds pretty bad, give hydroxycobalamin rather than nitrites or sodium thiosulfate to avoid increasing the methoglobin. True. Because you're afraid in the case of nitrites it can cause further cyanide poisoning, so just be aware of that as well. But it's funny because in the case of carbon monoxide poisoning, they say for both, like oxygen therapy only has a limited degree of impact, but apparently for carbon monoxide they do say, hey, if you want to treat it, you just have to like basically amp up how much oxygen you're really giving, like hyperbaric chamber level stuff, and just to see if you can competitively, if you can outcompete the CO, basically. That's interesting. My thing shows a little bit of a chart where it's showing the PaO2 versus the O2 bound to hemoglobin. And so for people who have normal CO2, you can see the normal thing, oh, okay, whatever. And then like halfway, that peaks at like plateaus at 20, but for the O2 bound hemoglobin. But it's going to be more like half of that, like 50% of that, what's normal. For both, you have a 50% hemoglobin anemia, and you also have a 50% carbon monoxide hemoglobin. So that's just trying to show that you can have a significant reduction in your ability to have oxygen-bound hemoglobin in the context of both anemia and in the case of CO, just having a carbon monoxide poisoning. Now we're in respiratory pathology, so that's going to be rhinosinusitis and stuff like that, which I think is in this book. Here we go. Okay. Respiratory pathology. Rhinosinusitis. Okay. Obstruction of sinus drainage into the nasal cavity, leading to an inflammation and pain over the affected area. Typically affects the maxillary sinuses, which drain against gravity due to an ostia located superomedially. Red arrow points to the red fluid-filled right maxillary sinus in A. Superior meatus drains posterior to the ethmoid. Middle meatus drains frontal, maxillary, and anterior ethmoid. Inferior meatus drains the nasolacrimal duct. Acute rhinosinusitis is most common causes of by viruses, like rhinovirus, for example. Rhinovirus, which is a picornavirus, which is a RNA virus, positive sense, single-stranded. If you want to start studying the virology stuff, you can, right? It may lead to superimposed bacterial infections, most commonly non-typable H. influenza, strep pneumonia, and M. catarrhalis. Paranasal sinus infections may extend to the orbits, cavernous sinus, and brain, causing complications, that is to say, things like orbital cellulitis, cavernous sinus syndrome, and meningitis. Epistaxis. Epistaxis, nose is a nosebleed, right? Epistaxis, a nosebleed, most commonly occurs in an anterior segment of the nostril, the Kieselbach plexus, at the caudal septum. Life-threatening hemorrhages occur in posterior segments, the sphenopalatine artery, a branch of maxillary artery. Common causes include foreign body, trauma, allergic rhinitis, and nasal angiofibromas, common in adolescent males. Less unfortunate. Kieselbach drives his lexus with his legs, superior labial artery, anterior and posterior ethmoidal arteries, greater palatine artery, sphenopalatine artery. Okay. Mine has a diagram. I would recommend just looking at the diagram of the nose. Be aware of the fact that when you talk about Kieselbach's plexus, we have the superior labial artery coming up from the nose, from the lip area. Hence the name labial, superior labial. One is coming from the anterior ethmoid, and one is coming from sort of like the sphenopalatine kind of. And also, apparently they also said the greater palatine as well is contributing to it as well. And apparently also posterior ethmoid has a contribution. So all that stuff is a contribution to Kieselbach's plexus. Now bear in mind that the anterior, like Kieselbach's triangle, that's the more common cause of nosebleeds. It's not particularly dangerous. It's when you get a nosebleed in the back of the nose that can be kind of a problem. So bear that in mind. Next is head and neck cancer. My sections are much more, a little bit more wordy for this stuff. Head and neck cancer. Mostly squamous cell carcinoma. Risk factors include tobacco, alcohol, HPV-16, oropharyngeal, EBV, nasopharyngeal, field cancerization. Carcinogen damages wide mucosal area, leading to multiple tumors develop independently after exposure. Nasopharyngeal carcinoma may present with unilateral nasal obstruction, discharge, and epistaxis. Eustachian tube obstruction may lead to otitis media plus or minus effusion and hearing loss. Laryngeal papillomatosis, also called recurrent respiratory papillomatosis, benign laryngeal tumor, commonly affecting areas of the stratified squamous epithelium such as the true vocal cords, especially in children, possibly from HPV transmission from mother to baby during labor. Associated with HPV-6 and HPV-11, symptoms may guide location of pathology, supraglottic leading to dysphagia, infraglottic/glottic leading to hoarseness. Okay. Next is pulmonary emboli. We're going to skip the DVT for now. Okay, pulmonary emboli. This is a sizable section. Pulmonary emboli, obstruction of the pulmonary artery or its branches by a foreign material, usually thrombus, that originated elsewhere. Affected alveoli are ventilated but not perfused. VQ mismatch, may present with sudden onset shortness of breath, pleuritic chest pain, tachypnea, tachycardia, hypoxemia, respiratory alkalosis. Large emboli or cytoembolus, red arrows show filling defects in the picture A, which you can see here, may cause sudden death due to clot preventing blood flow from filling the left ventricle and increasing right ventricle size, further compromising the left ventricular filling, obstructive shock. CT pulmonary angiography is imaging test for choice for PE. Look for filling defects. And you can see that in the picture B right there. EKG or ECG may show sinus tachycardia or less commonly the S1Q3T3 abnormality. Lines of Zahn, which is seen in picture... Oh, they flipped pictures B and C. So B is obviously that picture of the CT scan. For you, that's picture C. Picture C is a CT scan. And then picture B for you, but C for me in my textbook, is a picture of the lines of Zahn, or Zahn, Z-A-H-N, are interdigitating areas of pink, platelets, fibrin, and red, RBCs, found only in the thrombi formed before death, helps distinguish pre- and post-mortem thrombi. So again, I spoke about this in the previous video, or one of the previous videos about this book, is that if you want to determine the difference between pre-mortem and post-mortem, and this is true for bones as well. Did this damage to the body? Did this happen before they died or after they died? Because it's pretty relevant if you're trying to figure out what caused them to die, or what kind of chronic conditions or conditions they had before they died. Just trying to figure out what's going on. But in this case, it helps distinguish between a pre-mortem and a post-mortem thrombi. And thrombi are something that can form after you're dead. So if you want to figure out what's going on exactly, this will help you figure out the difference between the two. Treatment. Anticoagulation, that is to say heparin, direct thrombin/factor Xa inhibitors, IVC filter if anticoagulation is contraindicated. Types of emboli: fat, air, thrombus, bacteria, amniotic fluid, tumor, and embolus moves like a fat bat. So fat bat, fat, air, thrombus, bacteria, amniotic fluid, tumor, those are the things that can cause a emboli. Basically, something's just kind of hanging around, going through the blood vessels until it eventually blocks something, which can't kill you. Fat emboli associated with long bone fractures and liposuction. Classic triad of hypoxemia, neurologic abnormalities, petechial rash. Air emboli. Nitrogen bubbles precipitate in ascending divers. Is that the shakes? Well, caisson disease. The bends. It's called the bends. I'm thinking of something different now. The bends. Caisson disease, decompression sickness. Treat with hyperbaric oxygen, or can be iatrogenic, secondary to invasive procedures, that is to say, central line placement. True. Amniotic fluid emboli. Typically occurs during labor or postpartum, but can be due to uterine trauma, can lead to DIC, rare but high mortality. Okay. And now I'm on to the mediastinal pathology, which I don't know if they have a section on that. We'll have to check. Don't you love it when the book is basically a lot of the same content, but it's in different places, so you just have to figure out where exactly things are happening? Yeah, I'm not seeing it, so I'm just going to go to something else. But I'm going to just go read it off for you. Mediastinal pathology. Normal mediastinum contains the heart, thymus, lymph nodes, esophagus, and the aorta. Mediastinal masses. Some pathologies, for example lymphoma, lung cancer, abscess, can occur in a compartment, but there are common associations. Anterior, 4 T's, thyroid, substernal goiter, thymic neoplasm, teratoma, and terrible lymphoma. So again, that's thyroid, thymic neoplasm, teratoma, and terrible lymphoma. Middle, metastases, hiatal hernia, bronchogenic cysts. And posterior, esophageal cancer may present as a mass in or spread to middle mediastinum, neurogenic tumor, like a neurofibroma, or multiple myeloma. Okay. Mediastinitis. Mediastinitis, inflammation of the mediastinal tissues, commonly due to post-operative complications of cardiothoracic procedures, less than 14 days. Esophageal perforations are common with repetitive vomiting or contiguous spread of odontogenic retropharyngeal infection. Chronic mediastinitis, also called fibrosing mediastinitis, due to an increase in proliferation of connective tissue in mediastinum. Histoplasma capsulatum in common cause. Clinical features: fever, tachycardia, leukocytosis, chest pain, and sternal wound drainage. Pneumomediastinum. Presence of gas, usually the air, in the mediastinum can either be spontaneous due to rupture of pulmonary bleb or secondary, like in trauma, iatrogenic or Boerhaave syndrome. Boerhaave, and spelled B-O-E-R, Boer, H-A-A-V-E, H-A-A-V-E, Boerhaave syndrome. Ruptured alveoli allow tracking of air into the mediastinum via the parabronchial and paravascular sheaths. Clinical features include chest pain, dyspnea, short voice change, subcutaneous emphysema, plus a Hammond sign, H-A-M-M-A-N, Hammond sign, crepitus on cardiac auscultation. And now I see the flow loop stuff now. Look at my own textbook right just a second ago, and notice that the pharmacology section is pretty short, and the rest of the pathology section is still fairly long. So we'll have to trudge through it, I suppose. At least I have to trudge through it. You know, you can skip ahead if you really want to, or whatever. You know, I'm the one reading it. You know. Flow volume loops. Flow volume parameter. Normal. Obstructive lung disease, restrictive lung disease. So let's talk. There's the right ventricle, or is that right ventricle? Let's see. The residual volume, the functional reserve capacity, the total lung volume, the forced expiratory volume in 1 second. Forced. What is that? What does FVC mean in this case? Forced volume. Let's find my old stuff. Find the older page talking about this stuff. What the different words mean. FVC stands for, they don't even define it. Forced vital capacity, I believe, something like that. FEV1 divided by forced vital capacity just refers to how much air can you get out during the first second of expiration versus how much air you can get out in total. And that gives you a distinction between obstructive lung disease versus restrictive lung disease. So let's talk about it. So for normal, you have 80%. You have greater than 80% predicted value for FEV1, and greater than 80% for predicted for the forced vital capacity. And the difference between the first second versus divided by the overall expired air is about greater than 70%. So basically, you'll get more than 70% of your air out in the first second versus the overall air you could get out theoretically. What about obstructive lung disease? For obstructive lung disease, think about like COPD, for example. You have an increased residual volume because you have like a barrel chest. Your lungs get bigger, they hyperinflate, and they don't want to recoil. You have an increase in residual volume, an increase in functional reserve capacity, an increase in total lung capacity. You have a massive decrease in the forced expiratory volume in the first second. Basically, it's very hard for you to get air out of your body because it's obstructed. And your FVC might be normal, like your total ability to get air out of your lungs might be normal or it's slightly or somewhat decreased, but it just takes a lot longer for you to get all that air out. So the ratio between FEV1 and FVC is decreased because it takes you a lot longer to get air out of your lungs, and so the actual amount you can get in a second versus how much you can get in total will decrease. Because the amount in a second will decrease a lot more than the amount of air you can get out in total. It just takes longer. Now for restrictive lung disease, you have a decreased residual volume. Think about like, what's a good example of that? Let me think of a good restrictive lung disease. example. Asthma is a good one. Fibrosis, sure. Sarcoidosis, asbestosis, pneumoconiosis. I like asthma. Asthma is a good one. Acute interstitial pneumonia. Okay, so imagine you have one of those conditions. And now you have restriction. Now you have a decreased residual volume. You can't get as much air into your body now because it's restricted. Your functional residual capacity is also decreased because, again, it's restricted. Your total lung capacity is restricted. It's lower. Your FEV1 is lower, so your actual amount of air you can get out in 1 second is lower because you just have less air to begin with. Your forced vital capacity, FVC, is also lower, so your amount of air you can get out in total is lower. Makes sense. But your actual FEV1 divided by FEC, which is to say how much air can you get out in 1 second versus how much air you can get out in total, might be normal or increased because the reality is when you have a restrictive lung condition, you will have a lot of small, relatively short breaths. So you breathe in quickly, you breathe out quickly because you can't get all that much air in or out. And so the amount of air you can get in, realistically speaking, out in 1 second is pretty high compared to how much air you can get out overall. And that's just because the amount of total lung capacity is, for the most part, pretty limited. So, and you can see those graphs as well in there to kind of give you a comparison. Normal looks like is in the pink. And when you have an obstructive situation, you will have more air overall, but you can't get as much out, realistically speaking. So it might not be, I have more oxygen in my lungs or more air in my lungs, sure, but you can't get it out effectively. So you can't really cycle it through as easily. In the case of restricted lung diseases, it's kind of the opposite. In the same case, you actually have lower total volume, and you can probably get air out decently. You can get air out for the most part relatively easily in the first second or so, but you just can't get out as much air, and you can't get in as much air. You're just working with basically a smaller version of what you had originally, and as a consequence, it's not as efficient. Now we're going to talk about obstructive lung diseases for a moment. Obstructive lung diseases. Obstruction. Obstruction of airflow, major decrease in FEV1, decrease in FVC, and decrease in the FEV1/FVC ratio leads to air trapping in the lungs, increase in residual volume, increase in FRC, and increase in total lung capacity due to premature airway closure at high lung volumes, include COPD, chronic bronchitis and emphysema, asthma, and bronchiectasis. So I want to make a little bit of a correction. Asthma is actually an obstructive lung disease, not a restrictive one. Asthma is obstructive lung disease. Again, those are COPD, which includes chronic bronchitis and emphysema, asthma, and also bronchiectasis. Those are obstructive lung diseases. Now, chronic obstructive pulmonary disease, often due to tobacco use, most important risk factor, pollutants or allergens, include chronic bronchitis and emphysema, which often coexist. Exacerbation, acute worsening of symptoms, often associated with viral or bacterial upper respiratory tract infection. Chronic bronchitis. Diagnosis. Clinical diagnosis criteria: productive cough for greater than 3 months in greater than 2 consecutive years. May also have dyspnea, wheezes, crackles due to mucus, cyanosis, hypoxemia due to shunting, secondary polycythemia, i.e. it's a reaction to the main condition. Saying, we don't have enough oxygen, let's make more red blood cells, right? Leads to metaplasia of pseudostratified ciliated columnar epithelium into stratified squamous epithelium. So you get more stratified squamous as a consequence from metaplastic change. Mechanisms: hypertrophy and hyperplasia of mucus-secreting glands and bronchi. Notes: increase in Rida index, thickness of mucosal gland layer to thickness of wall between epithelium and cartilage, greater than 50%. Okay. Next one is emphysema. Emphysema, diagnosis: radiologic or biopsy diagnosis, chest x-ray, burial chest, increase in AP diameter, best seen in lateral view, which is going to be, I think, in the next page. I think that picture that you have is called D. I think that's the same one that they were talking about there. It looks like the picture that I have in my book. It looks like a barrel chest. I like to say that's a barrel chest, isn't it? Basically, you have typically a AP to lateral ratio of 2 to 1. So basically, your AP, your anterior-posterior ratio should be 1, and your lateral length should be 2. Like in terms of comparison, you should be twice as wide as you are long in terms of the anterior-posterior dimension. You're twice as wide as you are long, if you will. And as a consequence of that, in this particular context, if you have a barrel chest, it's basically a 2 to 2 ratio. It's the same length, more or less. So that would be an abnormal sign. And you can see that in emphysema. Flattened diaphragm, increase in lung field lucency. True. Mechanisms: alveolar wall destruction, leading to an increase in compliance of the lung, a decrease in recoil, and damage to alveolar capillary membrane, leading to a decrease in DLCO, resulting in an increase in airspace. There's two different kinds of emphysema. There's a centroacinar and a panacinar. Centroacinar spares distal alveoli, frequently in upper lobes, associated with tobacco and smoking. True. And I want to see if we can show those pictures again. So, the A that you have in your book, which is the C in mine, but the A in your book is showing that some of those centroacinar issues. For that picture, your A, and I think there's also another one here, which is going to be, I think, A and B. They're talking about for the tobacco smoking for centroacinar. Remember, centroacinar for smoking, tobacco use. There's also, what was the other picture? B. B was also for alveolar wall destruction. Your book says it's C. Same ideas. That's alveolar wall destruction, okay? Where are we? Oh, and emphysema. Yeah, okay, there we go. And that's also called, chronic bronchitis is called blue bloater disease. They don't mention this new book. I like the names. But emphysema is the pink puffer. And the other type is panacinar. Panacinar affects the respiratory bronchioles and alveoli, frequently in lower lobes, associated with the alpha-1 antitrypsin deficiency. So you will have a genetic issue where you have an alpha-1 antitrypsin deficiency leading to this particular issue that's panacinar. So it's across the whole thing. Affects respiratory bronchioles and alveoli, frequently in lower lobes. Well, granted, the centroacinar is going to be from smoking, tobacco, and that's going to be in the upper lobes. Yeah, exactly. Okay. So now we're going on. I think this is still continuing with the emphysema here. Mediated by oxidative stress, chronic inflammation, CD8 positive T cells, neutrophils, and macrophages, and an imbalance of proteases and antiproteases, leading to an increase in elastase activity and leading to an increase in loss of elastic fibers and leading to alveolar destruction. Defect/deficiency/absence of alpha-1 antitrypsin antiprotease that inhibits neutrophil elastase leads to unopposed elastase activity. Then we're talking about asthma. Asthma, intermittent obstructive lung disease often triggered by allergens, viral upper respiratory infections, stress associated with atopy, NSAID or aspirin-exacerbated respiratory disease, asthma, nasal polyps, and COX inhibitor sensitivity, leukotriene overproduction, leading to an airway constriction, Samter's triad. Diagnosis of asthma. Clinical diagnosis, intermittent episodes of dyspnea, coughing, wheezing, and tachypnea. Diagnosis supported by spirometry, obstructive pattern with bronchodilator response, but may be normal when not in exacerbation, plus or minus methylcholine challenge. Mechanisms: type 1 hypersensitivity reaction, smooth muscle hypertrophy and hyperplasia, hyperresponsive bronchi, leading to a reversible bronchoconstriction, and mucus plugging. And mucus plugging is shown in picture E for me, which I think is going to be something different for you. It just doesn't exist, so ignore that I said that, I guess. I don't know. mucus plugging for that. Other, for asthma, Kirschmann spirals, which is picture F. Let's see if we have it. We do not. Awesome. That's great. Kirschmann spirals. Oh, they say you have it in your book. They say that's Kirschmann spiral. They use a different picture, but yeah, that F picture there is Kirschmann spiral. The Kirschmann spirals shed epithelium forms whorled mucus plugs, charcoal-laden crystals, and G, which is G. That charcoal-laden crystal is G. I don't know if they have it in here. They do have it in here. So that's the same picture they have. Okay. Which is eosinophilic hexagonal double-pointed crystals formed by breakdown of eosinophils in sputum. Okay. And then we have one last, before we go into restrictive, we have one last obstructive disease, which is bronchiectasis. I vaguely remember looking at some of this stuff back in the past. Bronchiectasis, obstructive lung disease, most commonly associated with cystic fibrosis. Characterized by chronic cough and daily purulent sputum production, they often have recurrent pulmonary infections, confirmed by imaging demonstrating airway dilation and bronchial thickening, supported by obstructive PFT pattern. Pathophysiology. Initial insult of pulmonary infection combined with obstruction or impaired clearance, leading to dysregulated host response, and bronchial inflammation, leading to permanently dilated airways. Notes. Many etiologies, including airway obstruction, foreign body aspiration, mass, poor ciliary motility like tobacco smoking or Carter-Jenner syndrome, or cystic fibrosis shows a coughed up, impissated mucus plug. That's funny. Inspissated mucus plug. Allergic bronchopulmonary aspergillosis, pulmonary infections like Mycobacterium avium. So it could be a lot of different things that can cause bronchiectasis. But it's most commonly associated with cystic fibrosis. A lot of recurrent pulmonary infections. Okay. And now we're going to go to the restrictive stuff. I'm going to take a break and then come back to you. So I'll do that now. Oh, and if the break is a bit long, you can always skip ahead if you're not listening to it currently. Bear that in mind. Okay, I'm back. Here we go. Hello. Okay, here we go. Okay. And, okay. So we're going to go back into the restrictive lung diseases. Sure. Let's go back to that page. And let's see. Where were we? Restrictive lung diseases. How fun. And we only have, I think, a handful of pages before we reach the pharmacology. Well, a handful is being charitable. Pharmacology is on 703 for this section, and we're on 694, so there'll be a little bit of some time to it. Restrictive lung diseases. Restrictive lung diseases may lead to a decrease in lung volumes, decrease in FVC and total lung capacity. PFTs are normal or increase in FEV1 FVC ratio. Patient presents with short, shallow breaths, crackles, Velcro types, altered respiratory mechanics, extrapulmonary, normal D LCO, normal A gradient. So that's like the alveolar arterial gradient, I believe it is. Respiratory muscle weakness like polio, myasthenia gravis, Guillain-Barré syndrome, ALS, chest wall abnormalities, with the case of scoliosis or severe obesity. The other kind is the diffuse parenchymal lung diseases, also called intestinal lung diseases, pulmonary, decrease in DLCO, increase in the AA gradient in this position. So the AA gradient is going to be increased rather than normal, and your DLCO is going to be decreased rather than normal, and your pulmonary rather than extrapulmonary. These are pulmonary issues here. Pneumoconiosis, co-workers, pneumoconiosis, silicosis, asbestosis, okay. Sarcoidosis, bilateral hilar lymphadenopathy with a non-caseating granulomas, increase in ACE and calcium, idiopathic pulmonary fibrosis, granulomatosis with polyangiitis, pulmonary Langerhans cells, histiocytosis, eosinophilic granuloma, hypersensitivity pneumonitis, drug toxicity of bleomycin, busulfan, amiodarone, or methotrexate, and acute respiratory distress syndrome. Radiation-induced lung injury associated with pro-inflammatory cytokine release, that is to say, TNF-alpha, IL-1, IL-6, may be asymptomatic, but most common symptoms are dry cough and shortness of breath, plus or minus low-grade fever. Acute radiation pneumonitis develops within 3 to 12 weeks. Exudative phase, radiation fibrosis may develop after 6 to 12 months. Okay. And now we're going to go over to the list of them, I suppose. They start with inhalation injury and sequela, but I'm going to go into idiopathic pulmonary fibrosis. What is this? Idiopathic pulmonary... Do they not have that? Hypersensitivity? What do we have? That's fun. Yeah, I'm just losing my mind right now. Okay, so because I see mesothelioma, sarcoidosis, hypersensitivity, idiopathic pulmonary fibrosis. Is that just like, oh, it might be considered a different section? I think what happened is that they just kind of like brushed over everything. They just brushed over everything. Well, they kind of do that here too, to be fair. Yeah, whatever. So, this is talking about idiopathic pulmonary fibrosis. Progressive fibrotic lung diseases of unknown etiology may involve multiple cycles of lung injury, inflammation, and fibrosis, associated with tobacco smoking, environmental pollutants, genetic defects. Findings: progressive shortness of breath, fatigue, non-productive cough, crackles, clubbing, Imaging shows peripheral reticular opacities with traction bronchiectasis plus or minus a honeycomb appearance of lung advanced disease. Histologic pattern, usual interstitial pneumonia with a decreased type 1 pneumocytes and an increase in type 2 pneumocytes with increase in fibroblasts as well. Complications, pulmonary hypertension, right heart failure, arrhythmias, coronary artery disease, respiratory failure, lung cancer. It's basically, it's called idiopathic pulmonary fibrosis. These are progressive fibrotic lung diseases of unknown etiology. So it's a little bit of a black box, you could say. Let's see if we can find hypersensitivity pneumonitis or not. I'm not seeing anything. I wish they would just have a more consistent organization system, because I feel like it's not that different in terms of the content. Maybe the content is pretty different. We have ARDS. Okay. Hypersensitivity pneumonitis. Mixed type 3/4 hypersensitivity reaction to environmental antigens such as thermophilic, actinomyces, and aspergillus. Often seen in farmers and bird fanciers. Acutely causes dyspnea, cough, chest tightness, fever, headaches. Often self-limiting if stimulus is removed. Chronically leads to irreversible fibrosis with non-caseating granuloma, alveolar septal thickening, traction bronchiectasis. Oops, there we go. Okay, sarcoidosis. Do they not have this in here? I'm surprised. They make a big deal of it in this thing. Sarcoidosis. Whatever. Sarcoidosis, characterized by immune-mediated widespread non-caseating granulomas, elevated serum ACE levels, and elevated CD4/CD8 ratio in bronchoalveolar lavage fluid. More common in black females, often asymptomatic except for enlarged lymph nodes. Chest X-ray shows bilateral adenopathy and coarse reticular opacities, including ground glass opacities. Hear that word again, ground glass opacity. CT of the chest better demonstrates the extensive hilar and mediastinal adenopathy. Associated with Bell's palsy, parotid enlargement, granulomas, non-caseating epitheliode containing microscopic Schaumann and asteroid bodies, rheumatoid arthritis like arthropathy, increasing calcium, ocular uveitis, interstitial fibrosis, vitamin D activation due to an increase in 1-alpha hydroxylase in macrophages, skin changes like in lupus pernio, erythema nodosa, sarcoids. So again, that's an acronym, sarcoids. S for Schaumann and A for asteroid bodies. R for rheumatoid arthritis like arthropathy. C for an increase in calcium. Is this organized correctly? Yeah. Increase in calcium. O for ocular uveitis. I for interstitial fibrosis. And D for vitamin D, and then S for skin changes, like, again, lupus pernio, and erythema nodosa. How do you treat sarcoidosis? Glucocorticoids if symptomatic. Now mesothelioma, which again I'm trying to have issues trying to find in your PDF. Mesothelioma, malignancy of the pleura associated with asbestosis, may result in hemorrhagic pleural effusion, exudative, pleural thickening. Histology may show psammoma bodies, EM, may show polygonal tumor cells of microvilli, desmosomes, tonofilaments, calretinin, and cytokeratin, 5 out of 6 plus, positive in almost all mesotheliomas, negative in most carcinomas. Tobacco smoking is not a risk factor. So if you have mesothelioma, the smoking will not increase the risk for that. And so if you have the following, again, polygonal tumor cells, microvilli, desmosomes, tonofilaments, chororetin, and cytokeratin, you probably have a lot of those cases in mesothelioma, but you will not typically see that in a carcinoma. So now we're talking about pneumoconiosis. So I don't know. Now we're on this page, which is basically, it looks like it's more or less the same kind of page we had in this PDF. So I don't know if they just kind of like added that section into the new book, and it's not here in the old one, old PDF. I guess that's probably what's going on. Pneumoconiosis. Asbestos is from the roof, was common in insulation, but the effects the base, the lower lobes. Silica, coal, berries are from the base, but they affect the roof, upper lobes. Okay, so think about this. Asbestos on the roof. Where does it happen? Where does it affect? The base. Silica, coal, and the berries are from the base, right? Coal's from the earth. Berries are from the ground of the plants. Silica is from the sand, right? But they're going to affect the upper lobes. Opposite. It's kind of an inversion. Asbestos-related disease, sorry. Asbestos causes asbestosis, pulmonary fibrosis, pleural disease, malignancies associated with shipbuilding, roofing, plumbing. Ivory white, calcified supradiaphragmatic and pleural plaques are pathognomonic. Risk of bronchogenic carcinoma, increasing the risk of mesothelioma, increasing the risk of Kaplan syndrome, rheumatoid, increased risk of Kaplan syndrome, rheumatoid arthritis, and pneumoconiosis with intrapulmonary nodules. Okay. Affects lower lobes. Asbestos ferruginous bodies are golden brown fusiform rods resembling dumbbells found in alveolar sputum sample visualizing using Prussian blue stain, okay, often obtained by bronchoalveolar lavage. Increased risk of pleural effusions. And so that picture for they say the dumbbell appearance in your book is that picture C right there. And the picture B is for the plaques of pathognomonic asbestosis, as you can see in that case. Yeah, you can see them there, it looks like. And then A is a picture for the supradiaphragmatic and pleural plaques. Okay. So this is another way of looking at it, different ways to look at the A and B. I was talking about borreliosis. So, Prussian blue stain often obtained by bronchoalveolar lavage, increased risk of pleural effusions. Okay. Borreliosis. Associated with exposure to beryllium, as you can imagine, in aerospace and manufacturing industries, granulomatose, non-caseating on histology and therefore occasionally responsive to glucocorticoids, increased risk of cancer and cor pulmonale, and it affects the upper lobes. Coal workers' pneumoconiosis, prolonged coal dust exposure leading to macrophages laden with carbon, inflammation and fibrosis, also called black lung disease, increased risk of Kaplan syndrome. It affects the upper lobes, small, round, nodular opacities seen on imaging. Anthracosis is asymptomatic condition found in many urban dwellers exposed to sooty air. And the silicosis. Silicosis associated with sandblasting, foundries, and mines. Just think about where's silica in, right? Right, that makes sense. Macrophages response to silica release fibrogenic factors, leading to fibrosis. It is thought that silica may disrupt phagolysosomes and impair macrophages, increasing susceptibility to TB. Okay, interesting. Increased risk of cancer, cor pulmonale, and Kaplan syndrome. It affects the upper lobes, eggshell calcification of hilar lymph nodes on chest X-ray. The silly egg sandwich I found is mine. So sandblasting, foundries, mines. Okay, makes sense? It has an eggshell classification. And it's caused by, again, silicosis, the sand, Mesothelioma. That's in your book. I'm going to go to ARDS now, actually. I think we have an ARDS section in here. Yeah, right here. How much do we have left? We have about this many pages I went over before. I think about 10 pages left. Acute respiratory distress syndrome. Acute respiratory distress syndrome, pathophysiology. Alveolar insult leading to a release of pro-inflammatory cytokines causing a neutrophil recruitment, activation, and release of toxic mediators, that is to say, reactive oxygen species, proteases, etc., leading to capillary endothelial damage and an increase in vessel permeability, leading to leakage of protein-rich fluid into the alveoli, leading to formation of the intra-alveolar hyaline membranes, arrows in A, which I think is that picture down here. Doesn't show it. Okay. Well, you have a picture that's somewhat similar, I guess. Yeah, that your picture B is picture A for me, but it's just a different picture, but it's supposed to explain the same thing. And non-cardiogenic pulmonary edema, normal PCWP, leading to a decrease in compliance and VQ mismatch, leading to hypoxic vasoconstriction, leading to an increase in pulmonary vascular resistance. Loss of surfactant also contributes to alveolar collapse, that is to say, preterm infants drowning. Causes: sepsis is the most common cause of ARDS, aspiration pneumonia, burns, trauma, pancreatitis, drowning injuries. How do you diagnose it? Well, for ARDS, diagnosis of exclusion with the following criteria for ARDS. It's an acronym again. A, abnormal chest x-ray, bilateral lung opacities. And you can see something like that here with the chest x-ray that you see here. R, respiratory failure within 1 week of alveolar insult. D, decreased PaO2 over FiO2 ratio, less than 300, hypoxemia due to increase in intrapulmonary shunting and diffusion abnormalities. And then S, symptoms of respiratory failure are not due to heart failure or fluid overload. So if you notice there's an insult that leads to this problem and not rather than a heart failure issue or something like that, probably more likely to be ARDS at that point. Consequences of ARDS: impaired gas exchange, decrease in lung compliance, pulmonary hypertension. How do you manage it? Treat the underlying cause. Mechanical ventilation decreases the tidal volume. Increase in PEEP keeps the alveoli open during expiration. Sleep apnea. Repeated cessation of breathing, greater than 10 seconds during sleep, causing disrupted sleep and daytime somnolence. So basically, even if you're not necessarily totally aware of it, you're just waking up multiple times at night because you just stopped breathing. So even if you forget it, even if you wake up the next day and say, "Oh, I just got terrible sleep," and you don't even remember what happened, you can have situations like that. Repeated cessation of breathing, greater than 10 seconds during sleep, disrupted sleep, daytime somnolence. Diagnosis confirmed by sleep study, polysomnography. Nocturnal hypoxia, systemic and pulmonary hypertension, arrhythmias, AFib/flutter, sudden death. Not so fun. Hypoxia leads to an increase in EPO release, causing increase in erythropoiesis. Okay, so that's what's going on in sleep apnea. Not fun. Obstructive sleep apnea is a little more specific. Respiratory effort against airway obstruction. PaO2 is usually normal during the day, associated with obesity, loud snoring, daytime sleepiness, usually caused by excess parapharyngeal or oropharyngeal tissue in adults, adenotonsillar hypertrophy in children. Treatment: weight loss, CPAP, dental devices, hypoglossal nerve stimulation, and upper airway surgery. Central sleep apnea. Impaired respiratory effort due to CNS injury/toxicity. Congestive heart failure. Opioids. May be associated with Cheyne-Stokes respirations. Oscillations between sleep apnea and between apnea and hyperpnea. Treatment is positive airway pressure. So that's central. So central you have chain soaks breathing, C, CNS injury/toxicity, C, and congestive heart failure, C. It's a respiratory effort issue. What about obesity hypoventilation syndrome? Also called Pickwickian syndrome, obesity greater than 30 BMI, causing a hypoventilation, leading to an increase in PaCO2 during waking hours, retention, leading to a decrease in PaO2 and an increase in PaCO2 during sleep. How do you treat it? Weight loss, positive airway pressure. So sort of similar to what you do with central sleep apnea, in the sense that positive airway pressure is very useful in this context. Because what else could you really do in that situation? There's only so much you can do in that context. Okay, pulmonary hypertension. Elevated mean pulmonary artery pressure greater than 20 mmHg at rest results in arteriosclerosis, medial hypertrophy, intimal fibrosis of pulmonary arteries, plexiform lesions, and an increase in pulmonary vascular resistance, leading to increase in right ventricular pressure, leading to an increase in right ventricular hypertrophy, parasternal heave on examination, right ventricular failure. Etiologies. Pulmonary arterial hypertension, group 1. So pulmonary arterial hypertension, group 1. Often idiopathic, females greater than males. Heritable PAH can be due to an inactivating mutation in the BMPR2 gene, normally inhibits a vascular smooth muscle proliferation, poor prognosis. Pulmonary vasculature endothelial dysfunction results in an increase in vasoconstrictors, that is to say endothelin, and decrease in vasodilators, that is to say nitrous oxide and prostacyclins. Nitric oxide and prostacyclins. Other causes include drugs, that is to say amphetamines and cocaine, connective tissue disease, HIV infection, portal hypertension, congenital heart disease, and schistosomiasis. What about left heart disease, group 2? Causes include systolic and diastolic dysfunction and valvular disease. So bear in mind, by the way, that the number one cause of the number one cause of a right heart failure is a left heart failure. So if you have a right heart failure, there's a good chance you have a left heart failure that's causing it in the first place. So keep that in mind when we talk about pulmonary hypertension. It could be because of a left heart failure. That's a very common cause. That's group 2. Left heart disease causes include systolic, diastolic dysfunction, and valvular disease. Next, lung diseases or hypoxia, group 3. Destruction of lung parenchyma, that is to say, like in COPD, lung inflammation / fibrosis, for example, in interstitial lung diseases, hypoxemic vasoconstriction, for example, in obstructive sleep apnea and living in high altitude. Group 4, chronic thromboembolic conditions, recurrent microthrombi leading to a decrease in cross-sectional area of pulmonary vascular bed. Okay, and then group 5 is multifactorial. So causes include hematologic, systemic, and metabolic disorders, along with compression of the pulmonary vasculature by a tumor. Now let's talk about physical lung physical findings. So abnormality, breath sounds, percussion, fremitus, tracheal deviation. So pleural effusion. For pleural effusion, you'll see a decrease in breath sounds, dull percussion, a decrease in fremitus, and you'll see none or small tracheal deviation and away from side of lesion if it's large. So you'll have no deviation if it's small, but if it's serious, you will have a deviation away from the side of the lesion. So let's say you have a left-sided pleural effusion, it'll deviate to the right. Atelectasis. And your book says atelectasis, bronchial obstruction, but atelectasis. You have decrease in breath sounds, dull percussion, decrease in fremitus, and it will deviate towards the side of the lesion. Point to say it deviates towards the side of the lesion. Simple pneumothorax, decrease in breath sounds, hyperresonant percussion, decrease in fremitus, no tracheal deviation, which is interesting. Tension pneumothorax, decrease in breath sounds, hyperresonant for percussion, decrease in fremitus, and it'll have a deviation of the trachea away from the side of the lesion, away from it, because of the increased pressure. Consolidation, lobar pneumonia, pulmonary edema. You will have, in the case of breath sounds, bronchial breath sounds, late inspiratory crackles, egophony, whispered pectoriliquy. You have dull percussion, an increased fremitus. That's another thing too. You actually have an increased fremitus for consolidation or lobar pneumonia or pulmonary edema, increased fremitus, and you have no tracheal deviation. My book says digital clubbing. I think that's mentioned in your book, but I don't know where it was. I have to go find it again. Well, I'm not being particularly successful in that endeavor, have I been? Maybe I'm thinking about the DVT leg, and I'm just kind of confusing the two. Might be what's going on here. Yeah, I think that's what's going on. Yeah, I just don't have that section in here. Do we have atelectasis in here? I don't know. Do we have atelectasis? I'll just go to the next page and just see when it lines up again. Digital clubbing. Increase angle between the nail bed and the nail plate greater than 180 degrees. Pathophysiology, and you can just look at that by putting your two nails together to see if they're making that shape or not. Look that up. The shape that you're supposed to see in the case of nails, in the case of nail clubbing, it's because it won't form the typical shape that you would typically see. It's like a diamond shape. When you put your two fingers together, the last part of your digit, put from one hand and another together and make a little diamond shape. But if it doesn't form that like it typically would, it'll be a potential indication of digital clubbing. Anyway, for digital clubbing, pathophysiology is not well understood. In patients with intrapulmonary shunt, platelets and megakaryocytes become lodged in digital vasculature, leading to local release of PDGF and VEGF. VEGF is for angiogenesis. Can be hereditary or acquired. Causes include respiratory diseases, idiopathic pulmonary fibrosis, cystic fibrosis, bronchiectasis, lung cancer, cardiovascular diseases, that is to say, not cyanotic congenital heart disease, infections, that is to say, lung abscesses and TB, and others like IBD, not typically associated with COPD or asthma. Okay. Next is atelectasis. Am I sure there's nothing on this atelectasis at all? I feel like you would have mentioned something on it, right? Maybe not. Atelectasis. Alveolar collapse, right lobe collapse against the mediastinum A, which is just a picture they have given to me. And you can just look up atelectasis to kind of get an understanding of what it looks like. Multiple causes: obstructive. Airway obstruction prevents new air from reaching the distal airways. Old air is resorbed, that is to say, as a foreign body mucus plug tumor. Compressive. External compression on lung decreases lung volumes, that is to say, space occupying lesion, pleural effusion. Contraction, as that says, cicatrization. Scarring of lung parenchyma, that is CICATRIZATION, so that's CICATRIZATION. Cicatrization. scarring of lung parenchyma that distorts alveoli, like in sarcoidosis, adhesive due to lack of surfactant, that is to say, for example, in NRDS in premature infants, decreased via incentive spirometry or an increased PEEP during mechanical ventilation. And so there's 4 pictures. There's a normal lung, or there's an obstructive lung. You see it's obstructed, so it's not getting air to certain locations, so it's kind of it's kind of moving away. The pleura is moving away, the lung's moving away. Then there's a compressive type where the pleura is still kind of attached to the side, but the space is forming up between the different layers of the pleura that's compressing on the lung. That's full of fluid or something. That'd be like a pleural effusion, air, whatever. Then you have a contraction type where the pleura is detached from the wall of the chest and the whole lung gets shriveled up for some reason. And it has a lot of scarring in it. And the adhesive is more or less very similar to the contraction type. But contraction or cicatrization is more of a scarring issue initially, while the adhesive is more of a lack of surfactant that's causing this sort of lung collapse. Anyway, now we're on pleural effusions. Okay, so pleural effusions. Pleural effusions, excess accumulation of fluid between pleural layers, restricted lung expansion during inspiration, can be treated with thoracentesis to remove reduced fluid. Based on the Light's criteria, fluid is consistent with an exudate if pleural fluid protein/serum protein, increase in 0.5, pleural fluid LDH/serum LDH is greater than 0.6, or pleural effusion of LDH is greater than 2/3 upper limit of normal serum LDH. Okay, so exudate for that. Cloudy fluid cellular due to infection like pneumonia or tuberculosis, malignancy, connective tissue disease, lymphatic like in chylothorax, trauma. Often requires drainage due to increased risk of infection. Transudate. Clear fluid hypocellular due to an increase in hydrostatic pressure, for example in heart failure or sodium retention, and or decrease in oncotic pressures, for example in nephrotic syndrome or cirrhosis. So that's kind of basically a transudative situation of pleural effusion is very similar to the kind of condition you could get with just like an edema. So if you have like edema, it's like, well, what could cause it? Well, it could be an increase in hydrostatic pressure, or it could be a decrease in the plasma oncotic pressure. That can cause a transudative pleural effusion as well. Exudative is more of like an inflammatory situation, or an infectious disease process going on. And they have a picture. Your thing has its own little thing going on with it, but mine has a picture. There's a normal one, plasma proteins, then you have an exudative form where it's kind of getting, sort of this fluid is getting poured into the sides. And then transudative, where it's sort of also in the sides, I guess. Increased hydrostatic pressure is causing it. Okay. And a decreased colosmotic pressure as well. Okay. So pre-treatment. Now, this book has a thing for pre-treatment, post-treatment. Looks a lot better. Looks like an improvement. Now on to pneumothorax. Pneumothorax, accumulation of an air in pleural space, which you can see in the picture there for A. Dyspnea, uneven chest expansion, chest pain, decrease in tactile fremitus, hyperresonance, and diminished breath sounds, all on the affected side. Primary spontaneous pneumothorax. due to rupture of apical pleural, subpleural bleb or cysts, often most frequently in tall, thin, young males associated with tobacco smoking and vaping. Secondary spontaneous pneumothorax, due to diseased lung, bulle and emphysema, Marfan syndrome, infections, mechanical ventilation with use of high pressures, barotrauma. That's interesting. The mechanical pressure can do it as well. Mechanical ventilation causing high pressures can do it. Traumatic pneumothorax, caused by blunt objects like a rib fracture, penetrating like a gunshot, or iatrogenic, for example, central line placement, lung biopsy, barotrauma due to mechanical ventilation trauma. Tension pneumothorax can be from any of the above. Air enters the pleural space but cannot exit, increasing trapped air, leading to tension pneumothorax. Trachea deviates away from the affected lung, because again, increased pressure. And it's in picture B. May lead to increased intrathoracic pressure, leading to mediastinal displacement, leading to kinking of the IVC, leading to a decrease in venous return and a decrease in cardiac output. Obstructive shock, hypotension, tachycardia, jugular venous distension, needs immediate needle decompression and chest tube placement. So now that was page 700 for me. Now we're on page 701. Your book says 645, of course, so it's a little bit different, but you get the point. We are wrapping things up. We will be on the farm section relatively soon, I believe. Kind of. Pneumonia. We have type, typical organism, and characteristics. So lobar pneumonia, caused by strep pneumonia, obviously, Legionella, and Klebsiella. It looks like, in terms of characteristic, intra-alveolar exudate leading to consolidation. May involve entire lobe or the whole lung. Okay. So it might be a lobar or it might be in the entire lung for lobar pneumonia. Well, that makes sense. Lobar pneumonia, it might be lobar. It makes sense. Bronchopneumonia. That can be caused by strep pneumonia, Staph aureus, Haemophilus influenza, and Klebsiella. It's characteristic of acute inflammatory infiltrates from bronchioles into the adjacent alveoli, patchy distribution involving more than one lobe. So it's multi-lobar. Well, multiple lobes, I should say. It might be patchy in presentation, though, for bronchopneumonia. Interstitial or atypical pneumonia. It can be caused by mycoplasma, Chlamydophila pneumonia, Chlamydophila psittaci, which is like caused by birds, I believe. Well, you get it from birds. Legionella, Coxiella burnetii, viruses, RSV, CMV, influenza, adenovirus. These produce atypical pneumonias. Diffuse patchy inflammation localized to the interstitial area at the alveolar walls. Chest X-ray shows bilateral multifocal opacities. Generally follows a more indolent course, walking pneumonia. And, typically when we think about walking pneumonia, we think about mycoplasma pneumonia. They don't say mycoplasma pneumonia, they say mycoplasma. But mycoplasma pneumonia is the species, and that can cause an atypical or walking pneumonia. When you think about lobar pneumonia, think about strep pneumonia. Cryptogenic organizing pneumonia. Etiology is unknown, hence the name cryptogenic, right? Negative sputum and blood cultures often responds to glucocorticoids but not to antibiotics. Formerly called bronchiolitis obliterans, organizing pneumonia, BOOP, B-O-O-P. That's kind of funny. Not fun to have it, but, the acronym is kind of fun. Non-infectious pneumonia characterized by inflammation of bronchioles and surrounding structure. Aspiration pneumonia. Aspiration of oropharyngeal or gastric contents leading to a pulmonary infection. Risk factors include altered mental status, decrease in cough reflex or glottic closure, dysphagia, neurologic disorders like stroke, invasive tubes like nasogastric tube. Aspiration pneumonia presents days after aspiration, even in dependent lung segment. More common in right lower lobe if sitting up and right upper lobe if lying down, recumbent, due to the bronchial anatomy, can progress to abscess. Yeah. Aspiration chemical pneumonitis presents hours after aspiration event, due to gastric acid-mediated inflammation, presents with infiltrates in lower lobes, and resolves with supportive treatment. Now I'm going to natural history of lobar pneumonia, which is apparently a little bit different from what your book has. So just, I guess you guys have to follow me when I'm doing this. How long has this been running? Let's see. Not quite sure. I'll find out when it's over. Oh, it's 2:44. Okay. Well, yeah, that could be better or worse. I'm not quite sure. Let me think. So, it could be worse, I guess. I'm thinking like I have other things I got to do today, or that I should do today. Anyway, natural history of lobar pneumonia. So you have congestion, red hepatization, gray hepatization, resolution. So let's talk about lobar pneumonia. We start off with, let's say, this normal lung. You have this healthy alveoli, macrophage, capillary, white blood cell, whatever. Let's say congestion 1 to 2 days. Red-purple partial consolidation of parenchyma, exudate with mostly bacteria. So now you have some bacteria that are hanging out in there as well, and you have some more white blood cells. Red hepatization. Why say about hepatization? Because it almost looks like a liver, right? It's hepatization. It resembles that. 3 to 4 days, right? Red hepatization. Red-brown consolidation, exudate with fibrin, bacteria, RBCs, white blood cells. It's reversible still, though. So reversible. And so you have those bacteria hanging around, but now you have this fibrin and these RBCs. Or I should say, there's no the bacteria. I don't know if there's really bacteria there necessarily, but there's bacteria. It's bacteria. But now you see some RBCs, and you're seeing some exudate still. But now you're seeing some, some fibrin, some RBCs. Okay. Now we have gray hepatization, 5 to 7 days. Uniformly gray. Exudate full of white blood cells. Lysed RBCs and fibrin. So now you have lysed RBCs and you have some exudate and so forth, that kind of stuff. And now we have resolution. This is more than 8 days. This is after a week. Enzymatic digestion of exudate by macrophages. And so at this point, it implies that it might not necessarily be totally reversible at that point. Early on, sure. But when you have this full system of, now as everything's gray and you've gone through the whole process, it might not necessarily be entirely reversible. There's going to be some stuff hanging around after the fact, as you can imagine. Like fibrins hanging around, that kind of thing. Now we're going to go to lung abscess, which we have here as well. Lung abscess, localized collection of pus within parenchyma, caused by aspiration of oropharyngeal contents, especially in patients predisposed to loss of consciousness, that is to say with alcohol overuse or epilepsy, or bronchial obstruction, for example, in cancer. Air fluid levels often seen in chest x-ray. Presence of suggestion suggests cavitation due to anaerobes, for like Bacteroides and Fusobacterium, Peptostreptococcus, or Staph aureus. How do you treat it? Antibiotics, drainage, or surgery. So for lung abscesses are secondary to aspiration, is most often found in the right lung. Location depends on patient's position during aspiration. So if it's right lower lobe, if it's upright, right upper lobe, right medial lobe, it's recumbent. That's been said basically at least once or twice before, something along those lines. But yeah, lung abscesses can be caused by aspirations, although not necessarily, I don't believe. I think you can get it from other stuff. But abscesses, yes, you can get them from aspiration, certainly. Lung cancer. Lung cancer is what we're doing now. Again, we are on the wrapping up point. Yeah, pharmacology will be on 704. We're on 703 right now. it begins on page and during some parts of an 04 anyways. So lung cancer. Leading cause of cancer death is lung cancer. Presentation, cough, hemoptysis, bronchial obstruction, wheezing, mnemonic coin lesion on chest x-ray of non-calcified chest x-ray or non-calcified nodule on CT. Sites of metastasis from lung cancer, liver, jaundice, hepatomegaly, adrenals, bone, pathologic fracture, brain, lung mets, love, affective boneheads, brainiacs. So I don't even know what kind of learning device that is, but it says here, liver for L, A for adrenals, B for bone and brain. So lungs, lung mets, love, affective boneheads, brainiacs. I don't know what that means. In the lung, metastases, usually multiple lesions. So let me see. Liver. So sites of metastases from lung cancer can go to liver, can go to the adrenal glands, can go to the bone, can go to the brain, and so forth. Right, that kind of stuff. Liver, bone, adrenals, brain. Leave it at that. In the lung, metastases, usually multiple lesions, are more common than primary neoplasms, most often from breast, colon, prostate, and bladder cancer. Sphere. Sphere of complications: superior vena cava, thoracic outlet syndrome, Pancoast tumor, Horner syndrome, endocrine, perineoplastic, recurrent laryngeal nerve compression, hoarseness. Effusions, pleural or pericardial. Risk factors include tobacco smoking, secondhand smoke, radiation, environmental exposure, like radon and asbestos. Pulmonary fibrosis, family history, squamous and small cell cancers are central, and are often caused by tobacco smoking. Hamartomas are found incidentally on imaging, appearing as well circumscribed masses. But remember, sphere of complications for lung cancer: superior vena cava, Pancoast tumor, Horner syndrome, endocrine, and recurrent laryngeal nerve compression, and effusions. So, okay. Also, thoracic outlet syndrome. Okay, that's all. Gotcha. Understood. Or read, certainly. Understood. That's another question, perhaps. Okay. Let's talk about different kinds of lung cancers now. So, type, location, characteristics, histology. Small cell lung cancer. Small cell oat cell carcinoma. Location is central. Undifferentiated, very aggressive. May cause neurologic perineoplastic syndromes, Lambert-Eaton myasthenic syndrome, perineoplastic myelitis, encephalitis, subacute cerebellar degeneration, and endocrine perineoplastic syndromes like Cushing syndrome and SIADH. Amplification of MYC genes or MYC oncogenes, common. Managed with chemotherapy plus or minus radiation. Histology. Neoplasm of neuroendocrine, Kolchitsky cells, leading to small dark blue cells. Chromogranin A positive. Chromogranin A is positive. Neuron-specific enolase is positive, and synaptophysin is positive, just as a way to be aware of. So chromogranin A, enolase, neuron-specific enolase, and synaptophysin are all positive. And Kolchitsky cells are present, which are these dark blue cells. They're small. I definitely need to review this stuff. Non-small cell lung cancers. Let's talk about it. So non-small cell lung cancers include adenocarcinoma, which is peripheral. This is the most common number one primary lung cancer. primary lung cancer, most common subtype in people who do not smoke, more common in females than males. Activating mutations include KRAS, EGFR, and ALK. Associated with hypertrophic osteoarthropathy, clubbing, bronchoalveolar subtype, adenocarcinoma in situ. Chest X-ray often shows hazy infiltrates similar to pneumonia, better prognosis. Histology, glandular pattern often stains mucin positive, bronchoalveolar subtype, grows long alveolar septa leading to an apparent thickening of alveolar walls, tall columnar cells containing mucus. Squamous cell carcinoma, central, hilar mass, and you can see the hilar mass with the picture C that you have. Yeah, I think that's picture C for you. Hilar mass arising from bronchus, cavitation, cigarettes, hypercalcemia. Produces parathyroid hormone releasing related protein. So it's not actually parathyroid hormone, but it might as well be. It resembles it in many ways. It has similar effects. Causes, so think for histology, keratin pearls, which you can see in picture D, and intracellular bridges, desmosomes. Large cell carcinoma, peripheral, highly anaplastic undifferentiated tumor, strong association with tobacco smoking, may produce human chorionic gonadotropin leading to gynecomastia and large breasts, less responsive to chemotherapy, removed surgically, poor prognosis. Okay, so large cell carcinoma can cause increase in HCG. Okay, and pleomorphic giant cells you would see in the case of large cell carcinoma. So it makes sense, large cells, giant cells, right? And that's picture E that you can see there. And then we have bronchial carcinoma tumor, central or peripheral. Excellent prognosis. Metastases are rare. Symptoms due to mass effect, wheezing, or carcinoid syndrome, flushing, diarrhea. For bronchial carcinoma tumor, you have nests of neuroendocrine cells that are chromogranin A positive. So I just want to go over a couple different things for you off the bat. Does this continue to the next page? Yeah, it does. Well, kind of. Not well, it's Panco's tumors, but let's talk about these two different kinds of cancer so far. So, the ones that are small cell is small cell lung cancer, or oat cell. The non-small cell are adenocarcinoma, squamous cell carcinoma, large cell carcinoma, bronchial carcinoid tumor. Okay? The ones that are central are small cell carcinoma and squamous cell carcinoma. The one that is peripheral is adenocarcinoma and large cell carcinoma. When you think about Kolchitsky cells, think about small cell carcinoma, which are these small dark blue cells. When you hear Cushing syndrome, think about small cell lung carcinoma. When you hear about SIADH, think about small cell carcinoma. When you're hearing about the MYC or MYC oncogenes, I'll go into that later. So when you hear about when you hear about parathyroid hormone issues, including all the issues related to that, because parathyroid hormone breaks down bones. When you hear about parathyroid hormone excess or PTH related protein, think squamous cell. Squamous cell, PTH, bone issues, right? Calcium, hypercalcemia, squamous cell carcinoma. But when you hear about SIADH or Cushing's disease, think about small cell carcinoma. Okay, small cell for for SIADH and Cushing's disease. Squamous cell for PTH-RP. When you hear about human chorionic gonadotropin leading to gynecomastia, think about the large cell carcinoma. Okay, so that's that. What about the genes? If you're hearing about MYC oncogenes, MYC oncogenes, think about small cell carcinoma or oat cell carcinoma. When you hear about KRAS, EGFR, or ALK, think about adenocarcinoma. Make sense? When it's mucin positive, think adenocarcinoma. When it's chromogranin A positive or neuron-specific enolase positive or symptophysin positive, think small cell carcinoma. When it's chromogranin A positive. It could also be bronchiocarcinoma tumor, to be fair. Keratin pearls are squamous cell carcinoma issue. Why? Because keratin is made by squamous cells, so that makes sense, logically speaking. Just trying to make sure that you remember all these different kinds of details because it is relevant. Because they will ask you questions on the exam and say, well, what is it? And they say, oh, I don't know, because I know there's lung cancer exists, but I don't know which ones are which. You have to know the differences, basically. So we'll go to the next page. And they go to pharmacology directly. I actually have stuff on Pancoast tumor, so I don't know. I'll have to look into that. I think it's mentioned somewhere in here. Here we go. Pancoast tumor, also called superior sulcus tumor, carcinoma, most commonly NSLCLC, that occurs in the apex of the lung, may cause Pancoast syndrome by invading/compressing local structures. Compression of the local regional structures may cause an array of findings, including recurrent laryngeal nerve leading to hoarseness, stellate ganglion leading to Horner syndrome, ipsilateral meiosis, and hydrosis, superior vena cava leading to SVC syndrome, brachiocephalic syndrome, unilateral symptoms, brachial plexus, shoulder pain, sensoromotor deficits leading to atrophy, including that is, for example, atrophy of intrinsic muscles of the hand, and phrenic nerve, hemidiaphragm paralysis, hemidiaphragm elevation on chest X-ray. So there's a lot of different things that Pancoast tumor can cause. But if you think about what things are operating there and what they do, you can kind of get maybe a picture that something like that might be suspicious for Pancoast tumor. Superior vena cava syndrome. Obstruction of the superior vena cava, that is to say, like in thrombus or tumor, impairs blood drainage from the head, facial plethora. Note blanching after fingertip pressure in A, which is the picture that you see here. See the little pale spaces? Neck, jugular venous distension, laryngeo-pharyngeal edema, and upper extremities edema, commonly caused by malignancy, that is to say, like for example, mediastinal mass or Pancoast tumor, and thrombosis from indwelling catheters. Medical emergency. Can raise intracranial pressures if obstruction is severe, leading to headaches, dizziness, or an increase in risk of aneurysm, rupture of intracranial arteries. And I have a second picture. You have a different thing going on there as well with the LVRA, that kind of thing. I have a different picture where it shows more of like a jugular venous distension, upper extremity venous distension, and a thrombus obstruction leading to these issues. His blood's having difficulty getting back into the heart. And that actually concludes that section on pathologies. We're going to go into pharmacology now, but I'm going to take a short, well, I don't know how short it's going to be, but I'm going to take a break. Okay, now we're on to the pharmacology section. Pharmacology is a lot shorter than the pathology section, but it is not nothing. It's about 2.5 pages. So we'll try to get through it. We start off with antihistamines or asthma drugs. I'm going to start with asthma drugs. Your thing is a little bit, probably organized maybe a little bit differently, or somewhat differently. Asthma drugs. Is that a category here? Yeah, here it is. We'll have it aligned. Asthma drugs. Bronchoconstriction is mediated by 1, inflammatory processes, and 2, parasympathetic tone. Therapy is directed at these 2 pathways. Inhaled beta-2 agonists. Albuterol, short-acting, formoterol, relaxed bronchial smooth muscle, can cause tremor, arrhythmia. Albuterol is for acute symptoms. Inhaled or oral glucocorticoids. Fluticasone budesonide inhibits the synthesis of virtually all cytokines. Inactivated NF-kappa B, the transcription factor that induces production of TNF-alpha and other inflammatory agents. First-line therapy for chronic asthma, used as a spacer or rinse mouth after use to prevent oral thrush. Muscarinic antagonists. Tiotropium, ipratropium. Competitively blocks muscarinic receptors, preventing bronchoconstriction. Also used for COPD. Tiotropium is long-acting. Anti-leukotrienes, so LEU is in red. So what does it mean? Montelukast, zafarolukast, and Zoloitin. So montelukast and zafarolukast are anti-leukotrienes. Block leukotriene receptors, cysteine LT1 or cis-LT1, especially good for aspirin-induced and exercise-induced asthma. Zoloitin is a 5-lipoxygenase inhibitor, causing a decrease in conversion of arachidonic acid into leukotrienes, hepatotoxic. So its mechanism is a little bit different. It's preventing it from being made in the first place rather than necessarily blocking the receptor for Zoloitin. I mean, they might pronounce it Zoludin, but whatever. Anti-IgE monoclonal therapy. Omalizumab binds mostly to unbound serum IgE and blocks binding up to the Fc epsilon Ri. Used in allergic asthma with increase in IgE levels resistant to inhaled glucocorticoids and long-acting beta-2 agonists. Methylxanthines. We'll scroll down a little bit. Here we go. Methylxanthines. Mine's a little bit shorter. Theophylline likely causes bronchodilation. Well, mine's organized. My graph is different. That graph is not present in my book. Or if it is, it's somewhere else. Methylxanthines, theophylline, likely causes bronchodilation by inhibiting the phosphodiesterase, leading to an increase in cyclic AMP levels due to decrease in cyclic AMP hydrolysis. Limited use due to narrow therapeutic index, cardiotoxicity, neurotoxicity. Metabolized by cytochrome P450, blocks action of adenosine. PDE4 inhibitors. Roflumilast inhibits phosphodiesterase, leading to an increase in cyclic AMP, bronchodilation, leading to a decrease in airway inflammation, used in COPD to reduce exacerbation. And let me just go scroll. You can see this graphs right there. You can see, this is where avoidance is acting, where omalizumab is acting, where steroids act, where beta agonists, theophylline, muscarinic antagonists act, where steroids act, and anti-leukotrienes can act. It's a nice graph. It's good to have. So that's methacholine right there. Oh, is that it? For the PDF, that's it. Wow. That's not a whole lot. I thought there'd be more. So I went over PDE4 inhibitors, I think. Yeah, PDE4 inhibitors, roflumilast inhibits phosphodiesterase. Yeah, increases cyclic AMP, bronchodilation, decrease in airway inflammation, uses COPD, reduce exacerbations. Okay. Chromones. Chromoline prevents mast cell degranulation, prevents acute asthma symptoms, rarely used. I still have another page or two. I have 2 pages. Well, that's interesting. So asthma drugs continued. Oh, you know what? Let me go back up. If that's the end of that, I'm not sure if we want to go. We're actually going to biologics right now for anti-asthma drugs still. So let me just put anti-asthma just over here just to get the picture for you. But now we're talking about biologics that have anti-asthmatic properties, I guess. Mepolizumab, reslizumab against IL-5, benralizumab against IL-5 receptor alpha. Prevents eosinophil differentiation, maturation, activation, survival mediated by IL-5 stimulation for maintenance therapy in severe eosinophilic asthma. Dupilumab against IL-4 and IL-13. Okay. Soothe muscle cells. I'm just looking at this graph here. It's a lot to take in. So, my recommendation, if I were you, I would read the textbook for whatever sections you feel there's a deficit that you have personally in, once, maybe twice. Look at other sources. Look at Sketchy. Look at Words and Beyond. Maybe read a different textbook. I don't know. Review this video if you want to, perhaps. Something like that. H1 blockers. This is antihistamines. H1 blockers, also called antihistamines. Antihistamines, yeah. Reversible inhibitors of H1 histamine receptors, inverse agonists. First generation antihistamines, diphenhydramine, dimenhydrinate, chlorpheniramine, and doxylamine. Names usually end in N, ene, or N8. True. Clinical use: allergy, motion sickness, vomiting in pregnancy, sleep aid, because they can cause other symptoms besides simply the H1 effects. For allergies, it causes other things as well, which could be useful. Let's say, for example, if you want a sleep aid, but if you're not trying to go to sleep, then it could just make you drowsy. Adverse effects would include sedation, antimuscarinic, and anti-alpha adrenergic effects. True. Second generation are a little bit more specific. They're not as broad. They're really focused on simply the allergy question. So, second generation antihistamines include loratadine, fexofenadine, desloratadine, and cetirizine. Named usually ends in adine. There's a sketchy video on this. They use loratadine, fexofenadine, and I think cetirizine. They say loratadine like a rat, fexofenadine like a fox, and cetirizine like a satyr. So think about a forest with a satyr, a fox, and a rat, I guess. I don't know. Kind of goofy. But those are second gen stuff. They're used for allergies alone. And they have far less sedating than first generation antibiotics because they have a lower entry into the central nervous system. They don't really penetrate the CNS the same way, and so as a consequence, they have less sedative effects. Which is useful if you don't want to be drowsy when you're taking them. And now we're talking about dextromethorphan. Okay. Let's go down. Here we go. Dextromethorphan, antitussive, antagonizes NMDA glutamate receptors and can act as a hallucinogenic dissociative agent similar to ketamine at high doses. Okay. And that's interesting. And may be combined with bupropion as a fast-acting antidepressant. Synthetic codeine analog has mild opioid effects with use in excess. Naloxone can be given for overdose. Mild abuse potential, yeah, no kidding. May cause serotonin syndrome if combined with other serotonergic agents. Pseudoephedrine, phenylephrine. Mechanism: activation of the alpha adrenergic receptor in nasal mucosa, leading to a local vasoconstriction. Clinical use: reduces hyperemia, edema, used as a nasal decongestant, opens obstructed Eustachian tubes. Adverse effects of pseudoephedrine, phenylephrine: hypertension, rebound congestion, rhinitis medicamentosa. If used more than 4 to 6 days, so you get used to it, and then you stop taking it, and then it causes you to actually kind of reflexively increase the amounts you had before. It's kind of like an OD, well, not OD, like a withdrawal situation. Your body gets used to it, and then eventually, when it's no longer there, it rebounds. Rebound congestion. Associated with tachyphylaxis, can also cause CNS stimulation, anxiety pseudoephedrine. Okay. Pulmonary hypertension drugs. Let's talk about them. Endothelin receptor antagonist. Competitively antagonize endothelin-1 receptors, leading to a decrease in pulmonary vascular resistance. Clinical notes: hepatotoxic monitor LFTs. Example: bosentan. Bosentan is an endothelin-1 receptor antagonist. Bosentan. PDE5 inhibitors. So that your PDF basically names the drugs themselves, and my book just names the drug group, but they mention the examples within the notes. So PDE5 inhibitors. They inhibit PDE5, leading to an increase in cyclic GMP, causing a prolonged vasodilatory effect of nitric oxide. Also used to treat erectile dysfunction. Yes, it's true. Contraindicated when taking nitroglycerin or other nitrates due to risk of severe hypotension. Very true. Example would be sildenafil. Or tadalafil is another example. Prostacyclin analogs. So prostacyclin analogs, PGI2 prostacyclin with direct vasodilatory effects on pulmonary and systemic arteriovascular beds inhibits platelet aggregation. The adverse effects would be flushing, jaw pain. Examples would be epoprostenol and iloprost, as you can see right there. And then I have a little diagram here showing the effects of PDE5 inhibitors on GTP, inhibiting the GTP, nitrates encouraging the cyclic GMP, the prostacyclin analogs improving cyclic AMP, the endothelin receptor antagonists like the bosentan inhibiting the endothelin receptor, all that kind of stuff. That kind of stuff right there. And those are different pathways. I would just look that up if I were you. Anyways, so that concludes our respiratory section. These graphs are cool too. You can look at those. But yeah, that should conclude our respiratory section. If you wanted to go into the rapid review section, there's 2 other videos on that already. But if you've gone this far, thank you for listening. And have a great... it's been filming on Memorial Day, so if you were not me, you might be enjoying the day perhaps. And if you're listening to any other day, well, it's just as good, I suppose, in terms of review. Thank you, and goodbye.